Welcome you everyone. So here, let me fix my video. So welcome you everyone to our second session of our sixth batch, that is long clinical consultation under Secrets Unveiled Paces. So today we are going to discuss the neurology prompts, and this will be the first session of neurology. Basically, there will be 3 sessions to discuss the whole neurology prompts, and this will be the first session. So before starting for discussion the neurology prompts, let me have a recapitulation of the structure of history taking and a glimpse of this course structure, so that it will be easier for the new members who have joined from us today. So basically, this course is based on discussion on the prompts and then start the practicing. So what is actually prompt? Prompt is actually the given symptoms that are provided in the long clinical consultation of MRCP PACES exam. Like there are 2 stations of long clinical consultation in the PACES examination, station 2 and station 5. At each station will be given a definitive symptom. This is called prompt, like headache, like tummy pain, like low back pain, or fever, or memory loss. So we have to take the history from the patient, we have to formulate the differential diagnosis, then we have to proceed further. So in this course, we will discuss individually about approach to each prompt under specific system. So from the last 3.5 years, what we have identified, there are certain prompts that come in the PACES exam. And this actually happens all the time. There are 23 prompts from the neurology. From the gastroenterology, there are 12 prompts. From the musculoskeletal, there are 10 prompts. And all these prompts are discussed in sequentially in separate classes. So today we are going to discuss the neurology prompts. So after discussing the prompts, what we are going to do, we are going to provide the cases to the participants. Then also at the separate recording, that is the physical examination, investigation, and management are also provided to the participants. Then at the next session, from these prompts actually, cases are practiced so that the candidates get time to get themselves prepared. So let's recapitulate the structure of history taking again. So basically, after entering into the intro station, first you have to do introduction. How to do introduction? After entering the station, we have to tell that, hello sir, I'm Dr. De, one of the doctors working here today. We have to put a smiley face. This is to show the professionalism. Sorry. Then we have to tell, I am here to talk to you about your problem and examine you. Is that okay? We have to take permission from the patient before starting for the examination and talking to him. This is also a sign of showing professionalism. I will request everyone to do some mute, because this can create some problem in my lecture taking. Thank you. Then if at any point you have a question, please feel free to interrupt me anytime. Also inform the patient that I may take a few notes during our conversation, but rest assured, this will remain confidential. Then ask the open question. That is, in your own word, could you please tell me what brings you here today? Never goes like this, like from your survey or from your report, I have come to know that you are having headache or you are having low back pain. This will be closed question. So rather approaching with closed question, approach with a broader question like this word. And all these flowchart are given in the PDF section that will be available for the active participants. Then after introduction, we have to do symptom analysis. So how to do symptom analysis? For analyzing of any symptom, we can use this mnemonic. This is called ODPARA. Here O goes for onset, That is, how did it started? Did it started suddenly or gradually? Then D goes for duration. For how long you are having this symptom. I goes for initial episode, whether this is the first time you are having this kind of symptom. P goes for progression. We have to ask, do you think your symptoms is gradually increasing day by day? Then A goes for aggravating factor, R goes for relieving factor. You have to ask, have you noticed anything increase or decrease your symptoms? And last, A goes for associated features. So this goes for OD para. This is for almost all of the prompts, but for certain prompts, this OD para does not fit. And for that specific prompt, I will give you the specific written information, what you have to ask to the patient. We'll get it during our course. Then for any pain, the mnemonic is LICOR. This is for any pain. So what goes for LICOR? L goes for location. Any pain, we have to localize the pain. That is, where do you feel the pain? Then I goes for intensity. 1 being the lowest, 10 being the highest. How will you like to create the pain? Q goes for quality. We have to ask, what is the quality of the pain? Can you describe it for me? Then R goes for radiation. After starting from here, does it go anywhere else? This is to be done for any case of pain. So this is how you can do any symptom analysis. So we have done this part. Next, come to the systemic review. So I'm skipping this one. Rather than doing systemic review, let's look at the next section. That is PDF, POET, 5P, and Sajid. So this will be POET. So what does PDF and POET, Sajid, 5P means? PDF means P for past medical history, D for drug history, A for family history. Then Sajid goes for smoking, alcohol, job, impact on job and daily life, and D goes for driving. All these are important part of history taking. If you miss any point, you will lose your mark in clinical communication. And I will analyze, I will give you an idea how the marks are distributed in the later part of this discussion. So another thing is POET. POET goes for pet history, O goes for occupation, E goes for exposure, that is sexual exposure, and T goes for travel history. This POET is important only for 4 prompts specifically, that is cough, diarrhea, fever, and joint pain. Apart from these 4 prompts, POET is not essential for other prompts. Then please do a mute. It will be request to everyone to do some mute. If you have any question, you can unmute yourself. Then 5P. 5P is to be asked to any female of reproductive age. Here P goes for pill, and then period, then pregnancy, then abortion. I call it abortion to make it remember. Then P goes for partner. So this is the format of history taking. But there is a special trick here. What is the trick? In the PACES exam, if you want to get your diagnosis earlier, after doing introduction, then symptom analysis, directly go to the PDF. You will get to your diagnosis in more than 80% of the cases. This is my guarantee. This is 100% guarantee that without doing systemic review, after symptom analysis, if you directly go to the PDF, that is past medical history, drug history, and family history, you will get your diagnosis in more than 80% of the cases. Let me give you some real example, like the cases that came in the PACES exam. I will this time I'd like to have some interaction with the candidate. You have to ask me what is the diagnosis. These are real PACES exam cases. So this is a case at Delhi. Patient is having tingling and numbness. At hands and feet. Also around the mouth, that is periolar tingling and. At hand feet and perioral area. Whenever you are going to the past medical history, in the past medical history, the patient is telling that he has a past medical history of thyroid surgery. This is a case coming in Delhi. So can anyone tell me what is the diagnosis here? I'd like to have interaction from everyone.
Yes, hypocalcemia.
Yes, hypocalcemia. Due to what?
Post-surgery, post-thyroid surgery.
Yes, exactly, doctor. This is a very much popular case at the Delhi. This is hypoparathyroidism due to thyroid surgery. Okay, let me give you another example. These cases come in recent diet in the Thiruvananthapuram. This is also a very much important case. That is, patient is having tummy pain with breathlessness. This tummy pain and breathlessness is episodic. That is, it comes and goes. Whenever the tummy pain comes, also she feels breathlessness. Whenever you are asking the family history in the PDF, the patient is telling that her father also has the same problem. That is recurrent tummy pain and breathlessness. So what do you think? What can be the diagnosis? Yes, Dr. Das has already given the answer. Can anyone unmute and give the answer?
Hereditary angioedema.
Yes, doctor. Hereditary angioedema. These cases come 2 days back in the Thiruvananthapuram. Okay, another example. A 45-year-old male is having low back pain. This back pain is mechanical in nature. That is not inflammatory, not having any morning stiffness. In the drug history, the patient is telling that, in the past medical history, the patient is telling that he is having asthma. And in the drug history, he is telling that he is taking steroid for the past 4 months due to recent exacerbation. So what do you think? What is the cause of low back pain in this middle-aged man?
Osteoporosis.
Wonderful, doctor. Yes, so osteoporosis. Look how much it is important to go to the PDF. This is a hidden trick to get your diagnosis earlier. Let me give you another example. Suppose a patient is having fever. This case has come in the Bangalore center. So in the past medical history, the patient is telling that he is having recent dental procedure. And the fever is due to for 1 month. And the dental procedure happened 1.5 months back.
Infective endocarditis.
Yes, doctor, infective endocarditis. Look how easy is long clinical consultation. Actually, long clinical consultation is very much easy to approach if you know how to approach. Then let me give you another example. That case came yesterday. Patient is having polyuria and polydipsia. Suppose the patient is also having tight bowel, epigastric pain, and low mood. In the family history, the patient is telling that he has a family history of gland cancer or brain tumor. So what do you think? What is it? Yes, Dr. Das has wonderfully answered. Anyone?
One.
Yes.
Main one.
Can be main 1 or main 2. If there is brain tumor, it will be main 1. If there is gland cancer, it will be main 2A. Main 2B is never given in the PACES exam. Actually, what I want to tell that there is a certain pattern of cases that come in the PACES exam. After passing the MRCB PACES exam, what we are supposed to do? We are going to enter into ST3 phase in the training pathway. After entering into ST3, we are given a long period of training. That is ST4, 5, 6, 7, 8. After that, you are declared as a consultant. So we are not entering there as a consultant there. So they don't assess us as a consultant. They assess us whether we are able to handle the cases as a registrar or not. And every time, whenever you enter the exam hall, before entering the exam hall, a British examiner will come and will tell you it again and again that we are not here to assess you as a consultant. We are keeping here the cases that you face most often in the ward and daily practice. So basically, there is a pattern of prompts that come in the PACES exam. And from this course, I can make you guarantee if you complete the whole course and do the regular practice and as with the assigned homework, you will get common in your main exam of more than 95% of the cases. Up to now, it is 100% for sure. But for the safety, I'm telling that more than 90% cases, you will get your cases common exactly from the given symptoms that will be discussed during this course. Let me give you another example that I faced in my exam period. I passed for Pondicherry. So I was given a patient with headache and he was having high temperature. So it was a meningitis. After entering the station, I was asking him, do you have any past medical condition that I should be aware of? He denied. So what I want to tell you before that, one thing special, that is for the past medical history, you have to know what questions you have to ask. We are giving the written 8 sets of questions in the PDF. Because sometimes the surrogate will not give you the direct answer. That happened with myself and also happens with many other. Like whenever I ask the patient, do you have any past medical condition I should be aware of? He denied. Then I asked any surgery before. After that, he replied. In case of the fever case that came in the Bangalore, the candidate asked all the questions, but he denied all of them. At the point, whenever he asked any recent procedure, after asking this specific question, the surrogate replied that, yes, I had a dental procedure. So we have to know what questions we have to ask. So my suggestion will be to memorize these sets of questions. After entering into the station, we have to ask these questions by memorizing because we don't know from which sentence we can get our diagnosis. And in more than 80% of cases, sometimes 100%, you will get your diagnosis directly going to the PDF. So let me come back to my case, what I faced. So it was a headache with high temperature. He was a history of surgery. He told me that I had a road traffic accident. After that, I had a surgery at my tummy. So I removed the gown and saw that it was a splenectomy scar. So can anyone tell me what important questions then I have to ask the patient?
Vaccination.
Wonderful, doctor. Vaccination. I asked him.
Antibiotic.
Yes,
Antibiotic course.
vaccination and antibiotic, both has to be asked. And what is vaccination called with non-jargon? It is called shots. I asked the surrogate, did you take your shots as prescribed by the doctor? He replied that, no, I did not take it because I'm a poor man. I live in the slum, so I cannot afford. So at that point, I referred him to the social worker because he needs help, financial help. I also asked him, did you took the prescribed antibiotic or not? He told me that again, that I did not take it because I'm poor. So I got my diagnosis there. It was a meningitis due to encapsulated bacteria. After getting my diagnosis, I became focused. I could skip some important systemic review. I just took the I just asked the systemic questions, which I thought important. And I got 28 out of 28 at both my clinical consultation. So that is why asking the past medical history, drug history, and family history as early as possible is very much important. Suppose a patient is having hematuria. In the past medical history, the patient is having hypertension. This is an exam case. And in the family history, the patient is telling that in the family, I have kidney problem. And my brother died of brain stroke. What is the Dr. Das has already answered. Can anyone reply? What is the answer? What is the diagnosis here?
ADPKD.
Yes, doctor, ADPKD. That is why family history, past medical history, drug history, and family history is very much important to ask as early as possible if you want to get full mark and become focused. Regarding drug history, Also, there are specific sets of questions you have to ask. My suggestion will be to memorize these sets of questions, because in the exam center, you cannot think, you cannot remember and then ask the question. You have to be prepared beforehand, because in the exam center, the central memory does not work. The muscle memory only works. So you have to prepare beforehand. And regarding the drug history, one important thing you cannot miss, that is allergy to any medication, because this is the most favorite question or favorite thing by the British examiner. I'm giving you a real example that happened during this time. One of the candidates who appeared, who attended this course. So during my course, I again and again emphasize that this allergy to any medication has to be asked. So he got a case of loose motion. The candidate appeared at Delhi Center. So the loose motion was for 5 days. It was bloody in nature, watery motion, also bloody motion. The differential diagnosis came to be the infection or IBD. And as the patient was having family history of bowel cancer, we need to rule out malignancy also. So this was the differential diagnosis. But what is the twist here that he was the only candidate who asked this medication allergy. After asking, do you have any allergy to any medication? The surrogate replied that 5 years back, for some infection, I took a medication called penicillin. After that, I had some adverse reaction. And the doctor told me that I have penicillin allergy. So this penicillin allergy has nothing to do with the real diagnosis of the loose motion. And he was the only candidate who could identify the penicillin allergy, because he asked, do you have any allergy to any medication? That is why this question is very much important to ask. So this is all for past medical history, drug history, and family history. Then come to the poet. So what goes for poet? And yeah, there it is. So poet goes for, P goes for pet, O goes for occupation, E goes for exposure, that is sexual exposure, and T goes for travel. This poet history is important only for cough, diarrhea, fever, and joint pain. Let me give you an example. This is a real Paces exam case. At one time, a patient came with cough and breathlessness. This cough was dry cough, not producing any phlegm. Whenever asking about the pet history, the patient replied that he had pigeon. He used to love pigeon. He was a pigeon lover. So what do you think? What is the diagnosis here?
Extrinsic allergic alveolitis.
Yes, doctor. It's extrinsic allergic alveolitis. That is why it is very much important to ask the POET question only for cough, diarrhea, fever, and joint pain. Then, okay. Then you can go for Sajid. So Sajid goes for smoking. A goes for alcohol. Whenever the patient is doing smoking, you can do some safety netting that smoking is injurious to health. If you want, we can refer you to the smoking cessation clinic. For alcohol, if the patient takes alcohol within social limit and his liver is not affected, never go for reducing the alcohol intake. Because if you tell to reduce the alcohol intake in spite of having taken it within social limit, you will lose your mark by the British examiner. And whenever the patient tells you that he exceeds the social limit and sometimes binge also, then you have to ask the Cage questionnaire. So what is a Cage questionnaire? C goes for, have you ever felt that you should cut down your drinking? That is cut down. A goes for annoyed. Have people annoyed you by criticizing your drinking? G goes for guilt. Have you ever felt guilty about your drinking? Then E goes for eye opener. Have you ever had a drink first thing in the morning to steady your nerves or get rid of a hangover? So this gauge questionnaire is to be asked when the alcohol drinking crosses the safety limit, also in case of some binge drinking. Then come to the job. After asking the job, we have to ask how does this symptom is affecting your job and daily activity. This is a must to ask question. If you miss the question to ask this question, you will lose your mark for sure. Then last come to the driving. For driving, there is specific prompt where you have to stop the driving. But here is a bonus clue for all of you. Sometimes in certain scenario, we are confused that whether we have to stop driving or not. At that scenario, we can skip by telling this question answer. That is, stop driving till further assessment. Why this is important? Because in the UK, there is a separate department called DVLA to deal with this matter. It is not necessary for the doctor to memorize all the indication, all the period that is required for driving license. Like whenever anyone has hypoglycemia, how long he cannot drive. Whenever anyone has acute coronary syndrome, how long he cannot drive. It is not a doctor's job. This job is done by the DVLA. So you can directly refer this patient to the DVLA. In spite, if you have any confusion, just ask the patient how this symptom is affecting your driving. As you are having this symptom, I will suggest you to stop driving till further assessment. This is to keep you at the safe side. So this goes for SAGIT. After doing SAGIT, we have to approach for the physical examination. After doing physical examination, we have to meet the concern. During meeting concern, we have one of the concern is common there, that do I need admission? So in the PACES exam, you will be given two types of scenario. One is acute, another one is stable. Sometimes in some scenario, we can be confused that whether the patient needs admission or not. In that case, you can skip yourself into safe side by telling this line. What is the line? If the patient asks you that, do I need admission? You can tell that I would like to keep you at the observation room. I would like to keep you at the observation room. In the meantime, our consultant will come and see you. After that, I will meet your concern in detail. This is to keep you in the safe side. You are not discharging the patient, neither you are keeping the patient. You are just keeping him in the observation room and you are calling your consultant. So you can skip your confusion by telling this, that I would like to keep you at the observation room. So these are simple tricks. Dr. Shubhadev has asked which one is acute, which station will be acute and which station will be chronic. Actually, it is basically, it cannot be told by anyone which will be acute and which will be chronic. There are two stations, 2 and 5. Station 2 and station 5 will cover the long clinical consultation. So anyone can be acute or anyone can be chronic or stable case. So, but for sure, one will be acute and one will be stable. And the acute case will be dummy case. I will tell you what is dummy case and what are real cases. So in this way, you can proceed. Regarding the systemic question, it is your choice whether you want to ask all the systemic question or you can become focused after getting your diagnosis and differential diagnosis. These are the sets of questions. What questions we have to ask for each system. These are given in details in the PDF. This PDF is available for the active participants. In the PDF, there is also another set of things, that's the diabetes questionnaire. Whenever any long-term diabetic patient is given in the PACES exam, we have to ask a lot of questions. So what are the questions? All are given here in written form. The questions is, first we have to ask, do you have any high blood pressure? For how long? How is it was diagnosed? Whether it was routinely diagnosed or by some emergency. Emergency meaning this was a likely case of DKA. That is, it is type 1 diabetes mellitus. What medication are you taking for? Do you go to your eye doctor, kidney doctor, and foot doctor at regular intervals? Fifth question will be, may I know your last 3 months average blood sugar report, which is called HbA1c. This will be the general question for any diabetic. Then we have to check for the compliance. For checking the compliance, we have to ask the triple D, that is drug, diet, and daily exercise. Are you compliant with the medication? That is drug. Are you following the recommended diabetic diet? That is diet. Are you doing regular physical exercise? This is to check that compliance to triple D. Then we have to assess for first hypoglycemia and hyperglycemia complication. Any episode of low blood sugar coma, that is hypoglycemia. Whenever there is hypoglycemia, we have to inform the DVLA and stop the driving. Then any episode of high blood sugar coma, that is DKA or HHS, that is hyperosmolar coma. Then we have to assess the microvascular complication. What are the microvascular complications? It is peripheral neuropathy, then retinopathy, and nephropathy. So we have to ask, do you feel any tingling and numbness at your hands or feet? Any vision problem? What about your urine? What about the amount? What about the color? What about the frequency? Is there any frothiness or not? Then for macrovascular complication, we have to check whether the brain is affected, whether the heart is affected, whether the artery is affected. For brain, we have to ask any weakness or previous episode of weakness, that is stroke or TIA. For heart, we have to ask any chest pain at rest or while walking, exclude MI or angina. To exclude peripheral vascular disease, we have to ask any pain at the back of your leg while walking. These are the microvascular complications. Then come to the autonomic complication. For the autonomic complication, to assess postural hypertension, we have to ask, do you feel dizzy standing from the sitting position? Then in autonomic neuropathy, the GIT motility reduce. That is peristalsis reduce. So the patient will, there will be early satiety. So we have to ask, do you feel full after eating? There will be gustatory sweating. So we have to ask any increased sweating while eating. Then there can be alternative constipation and diarrhea, because in autonomic neuropathy, the motility of the gastrointestinal tract is reduced. Eventually, the bacteria proliferates there, and there happens small intestinal bacterial overgrowth. So we have to ask, what about your bowel habit? Any loose motion? Any tight motion in between the episodes of loose motion? Then the last question will be question of erectile dysfunction in case of male, not in case of female. We have to ask any problem in your intimate relationship. So these are the diabetic questionnaire. This is available in details in the PDF. It will be provided to all of you. Then these are the rheumatological sets of questions. It will be discussed as the situation, as the prompt arises. So this is all for history taking. Now let us give a small idea about the mark sheet, because this is one of the most important things we have to know if we want to get full mark in the PACES exam in the long clinical consultation station. So in station 2 and station 5, in both of the cases, the examiner will be given this mark sheet. There will be 2 examiners in each station, and with each examiner, he will have this mark sheet. So this is the only station in the PACES exam where all the 7 skills are assessed. That is physical examination, identifying physical signs, clinical communication skill, differential diagnosis, clinical judgment, managing patient concern, and maintaining patient welfare. Each skills only scores 2 marks at the highest. So all the 7 skills in total counts 14 marks. So each examiner has in his hand only 14 marks to give. And combining both examiner mark, you will be given the mark. So let me analyze one by one skill, how the skills are assessed in the long clinical consultation station. But before discussing the skills, I want to tell something special that you can follow. That is the triple CA. Because if you follow this pattern, there will be nothing you will miss. So what does triple CA means? Triple CA means first to confirm the diagnosis, then to find out the cause or trigger of the diagnosis, then to find out the complications. At last, we have to rule out the association. But all the components you will not find for all the prompts. Sometimes some parts will be missed there. How some parts will be missed, it will be discussed in detail as the prompt arises, and also in the separate recording of the physical examination, investigation, and management for each of the cases. There are total more than 250 cases that we will provide to the candidate individually. So this triple C and A has to be assessed from the history, from the physical examination, and from the investigation. Let me give you an example, so that it will be easy for you to understand. Suppose you have been given a prompt of swallowing difficulty. This is a prompt, and this is a triple star prompt. This prompt will be discussed under the GAT scenarios. And the diagnosis is myasthenia gravis. Suppose the diagnosis is myasthenia gravis. So from the history, first we have to confirm our diagnosis. We have to confirm our diagnosis of myasthenia gravis. How to confirm it? We have to ask about the pattern of weakness, whether the weakness increases at the later part of the day or not. Then we have to find out the cause or trigger. Myasthenia gravis is an autoimmune disease. So the cause is autoimmune. So from the history, we cannot ask any question that indicates that this is autoimmune. But for myasthenia gravis, there can be certain trigger, like drug causes can be there. In the PACES exam, frequently they give certain cases, like recently the patient was having flu-like symptom and she has taken azithromycin for that. There can be underlying his infection, or there can be recent surgery that can aggravate the myasthenic crisis. So in this way, we have to find out the cause from the history. Is it clear to everyone? Then we have to find out the complication. So what is the complication of myasthenia gravis? Myasthenia gravis can cause respiratory failure. So from the history, we have to rule out respiratory failure. We have to ask, do you feel breathlessness at rest? Also, for swallowing difficulty, any swallowing difficulty can have aspiration pneumonia. So we have to ask, do you have any cough and do you produce any film? Because in case of aspiration pneumonia, the patient will produce productive cough. So in this way, from the history, we have to rule out the complication. Next, come to the association. Myasthenia gravis is an autoimmune disease. There is a mnemonic to remember all the autoimmune diseases. The mnemonic is DAT, CPR, MV. Here D goes for diabetes, A goes for Addison's, T goes for thyroid, C goes for celiac disease, P goes for pernicious anemia, R goes for rheumatoid arthritis, M goes for myasthenia gravis, V goes for vitiligo. So from the history, we have to rule out all the autoimmune association. How to rule it out? For diabetes, we can ask, do you ask the symptom? We can ask the symptoms of polyuria and polydipsia. Do you have increased thirst? What about your water work? For Addison's disease, do you feel dizzy after standing from the sitting position? For thyroid, we have to ask any weather preference or not. For celiac disease, we have to ask, do you have any loose motion? For pernicious anemia, we can ask, do you think you are getting pale day by day? For rheumatoid arthritis, we have to ask, is there any joint pain? This is a case of myasthenia gravis itself. For vitiligo, we can ask any skin rash at any part of your body. So in this way, from the history, we have to follow the triple CA formula. I think this is clear to all. Now I am proceeding to the physical examination section. Let's
What
come
do
to
you,
the, sorry, does Dr. Shubhadeep, please ask.
yeah, sorry, what do we ask for the vitiligo? We have a specific history for vitiligo as well.
Any skin rash.
Oh.
Okay, I'm saying there is another question in the chat box. Dr. Ovik has asked, in all diabetic patients, we have to ask the diabetic question only, or no, not for all the diabetic cases. When there is long-term diabetes, that is more than 10 years, then we have to ask about the diabetic complication. The diabetic patient who has been recently diagnosed, like 3 or 4 years, it is not necessary to ask the diabetic complication. Then come to the physical examination section. For this patient, first to confirm our diagnosis, okay, it's a physical examination. So first confirm our diagnosis of myasthenia gravis, we have to do certain steps of examination of myasthenia gravis. What are the steps of examination of myasthenia gravis? This is discussed in detail with all the steps in a separate recording. And I will provide it to all the active participants. You have to take your preparation, and at the next session, you have to practice one-to-one with me. In the meantime, also you have to do the homework with your assigned partner. So from the examination, we have to confirm that this is myasthenia gravis, and you have to memorize what are the steps of examination in any case of myasthenia gravis. Then to find out the cause or trigger of myasthenia gravis, basically there is no physical examination. So this is the case where all the parts does not fit all the time. So in this case, to find out the cause or trigger, we cannot do any physical examination. Then to find out the complication, what can we do? To find out the complication, one complication is respiratory failure. So we have to offer bedside force vital capacity to exclude the respiratory failure during physical examination. To exclude aspiration pneumonia, we have to auscultate the chest, looking for any crepitation. If you auscultate the chest, the examiner will understand that you are ruling out aspiration pneumonia. And during examination, you will see that one examiner will sit at chair and another examiner will walk around you to see what are the steps you are doing, whether you are missing any important parts or not. Then come to the association. So from the association, how to rule out the association? To rule out that CPRMV, to rule out diabetes and Addison's, we have to offer measuring of bedside blood sugar and measuring of postural drop. That is, we want to measure the blood sugar in sitting and standing position. To rule out thyroid, we have to check for neck swelling. We have to tell the patient, take a sip of water, don't swallow it until I tell you to swallow. Then after coming at the level of the patient, we have to tell the patient to swallow to check whether there is any goiter or not. For celiac disease, we don't have to do any physical examination if in the history the patient does not give any history of loose motion. For pernicious anemia, we have to check the conjunctival pallor and tongue for glossitis. For rheumatoid arthritis, if in the history the patient is not telling any joint pain, we don't have to do the examination of the joint. For vitiligo, we have to tell the examiner that I want to do full skin survey to rule out any hypopigmented skin rash. The examiner understands that you are ruling out vitiligo. Sometimes the vitiligo can be evident at the hands and feet. If it is not visible, we have to offer to examine the whole skin to rule out vitiligo. Is it clear to everyone? Please tell me or give a thumbs up reaction so that I can proceed to the investigation section. Do anyone have any kind of question regarding the history and physical examination? How to exclude the CCCA? Is it clear to everyone? Okay. Then come to the investigation. In the investigation, also we have to follow the CCCA formula. So always before telling for any investigation, start with the line that apart from basic investigation, this is the line you have to tell for all the investigation scenario. Because if you miss this line, the examiner will cut your mark in the clinical judgment. And I can show you direct feedback from the RCP where the candidate missed to tell this basic investigation. These are very much simple thing. Then, apart from basic investigation, to confirm my diagnosis of myasthenia gravis, we have to do anti-acetylcholine antibody test. If it is negative, then anti-mask antibody test. We can also go for single fiber electromyography and NCS after repetitive nerve stimulation. So these are the investigation to confirm my diagnosis. Then to find out the cause or trigger, we have to, from the complete blood count of the basic investigation, we have to check for any evidence of infection in the form of neutrophilia, that is increased WBC count. We have to give the answer in such way, and the examiner will be very much impressed with you if you tell in such way. So from the complete blood count, we are seeing whether there is any evidence of infection, because infection can trigger myasthenia gravis. Then for the complication, for the respiratory failure, we can do spirometry. And to rule out aspiration pneumonia, we can do chest X-ray. Then for the association, for ruling out diabetes, we have to do fasting blood sugar and HbA1c. To rule out Addison's disease, we have to do check 9 AM serum cortisol. We can check thyroid function test. Then from the complete blood count, we have to look for the evidence of anemia, and that's all. For celiac disease and rheumatoid arthritis, no investigation is required if in the history the patient does not tell you any positive symptom. And what are the investigation has to be told? These are given in recording in a separate section. Basically, in this course, we are going to make practice of each candidate more than 250 real basis exam cases. These are the cases that appear in the last 3.5 years at different centers. So what are we going to do? Suppose today we are going to discuss some neurology prompts. So from these prompts, we have identified the cases, and the cases will be distributed to the active participants. And in a separate recording, there will be what are the physical examination you have to do for each cases, including the investigation and management will be there. So you have to take preparation for the given prompts and the given scenario. Then you have to start practicing with other participants of the group, or the active group. Then at the next session, all will have to do one-to-one practice directly with me. I will assess how have you practiced after the last class. This is some kind of homework. I will exactly give scenario from this point, from these prompts. I hope this is clear to everyone how to rule out CCCA. Why this is important? I'm telling you that. The first skill is physical examination skill. If the examiner is satisfactory, he will give you 2 marks. If the examiner is not that much satisfactory, he will give you borderline and will give you 1 mark. Yes, any question, doctor? Anyone asking any question? Okay. If he is not satisfied, that is unsatisfactory, you are likely to get 0 mark. So basically for each skill, each examiner has 2 marks at hand. And for the physical examination, if you follow the format of CCCA, you are likely not to miss any important part of physical examination. Basically, there are 2 ways by how you can do the physical examination. One way is the traditional way, that you can start from the hand, doing some general examination first. That is, I want to rule out clubbing, anemia, tremor. Then from the eye, I would like to check the anemia, jaundice. So this is the general way. This is, of course, good. But what is the drawback of that way is that you can miss some important part of the examination. So to not to miss it, if you follow the format of CCCA, that is, first we have to do the examination to confirm my diagnosis. Then I have to do the examination to find out the cause or trigger. Then I have to do the examination if there is any complication. Then I have to do the examination to rule out association. If you follow this way, you will get satisfactory, and the examiner, both of the examiner will award you with 2 marks from each. The next skill is identifying physical sign. There is an important thing to tell about this. In the PACES exam, you will get 2 cases. One is acute and another one is stable case. And in the PACES exam, sometimes they give some dummy patient. The patient is likely the nurse or a medical student. He's not a real patient. And you will not get any positive physical finding from that patient. Suppose there is a very common case of hematemesis. You are talking to a young boy, likely he is a medical student. He will give you history that recently I attended a football match. I got hurt myself and I took painkiller, but I did not took the tummy protective medication. So from today, I am having recurrent episode of bloody vomiting, about 5 to 6 episodes. So whoever is having 5 to 6 episodes of blood vomiting, that is hematemesis, likely you will find some anemia. But whenever you are doing the physical examination, you will not find any anemia of that patient because he will be a dummy patient. So why I am telling this? I am telling this because for the PACES exam, omitting is better than committing. What does this mean? This means that synthesizing any sign is a great sin in PACES exam. If you synthesize even one sign, you will be awarded 0 mark in the identifying physical sign. Suppose system sclerosis patient has been given to you. There are lots of findings in positive physical findings in any case of system sclerosis patient. You have suppose you have identified some wonderful thing like skin thickening, then skin ulceration, then puckering of face, some wonderful 5 to 6 positive physical finding. But the patient is not having loud P2. But if you synthesize and tell that I'm finding loud P2, in spite of getting some wonderful physical finding, the examiner will give you unsatisfactory. That is why synthesizing is strongly prohibited in PACES exam. And it is important in case of dummy cases, because in the dummy cases, you will not get any positive physical finding. So for matching your diagnosis, if you tell that I'm getting the anemia, the examiner will give you unsatisfactory and 0 mark. This is for sure. So whenever you are not sure enough about any positive physical findings, rather keep silent. Because if you synthesize any one finding, you will be given unsatisfactory. Suppose pulmonary embolism is a very much common case in the PACES exam. And never ever a real pulmonary embolism patient will be given in the PACES exam. It will be a dummy case, 100% sure. So for matching, if you're for matching your diagnosis, if you tell that I'm getting rest, JPP, loud P2, something like that, you will be given unsatisfactory in the identity physical signs, and you will not understand anything from the expression of the examiner there. So please be assured that not to synthesize any physical finding. If you are not sure enough, skip that part. That is better, because omitting is better than committing in PACES exam. So the third skill is clinical communication skill. Clinical communication skill is the most hardest part, and this is the part where the candidate has to do a lot of work. This is actually the format of history taking that I have provided to you. So before entering into the station, after getting the prompt, what will be your task? That you have to format yourself. You'll be given a blank page. If it is possible, you can write these steps so that you don't miss anything in the history taking, because all these will carry mark in the clinical communication skill. In the clinical communication skill, the examiner will see whether you are analyzing the symptom, whether you are touching the PDF Saji, whether you are doing important safety netting. What is the safety netting? Sometimes the patient can tell you that I'm having some rash over my face whenever I'm going to the sun. So you have to tell the patient that avoid sun exposure. The patient can tell you that symptoms of Raynaud's phenomenon. So you have to tell the safety netting of avoid cold exposure. Sometimes the patient can come with you with the rash of vitiligo. You have to tell the patient that stop, avoid sun exposure, because this can aggravate your skin rash. Sometimes the patient can tell you that I'm having low urine output and I'm taking painkiller. So you have to tell the patient that stop taking this painkiller. These are the safety netting, and all of the safety netting will be discussed for each prompt separately during this whole course. Also, you have to ensure safety of the patient after the patient goes back to home. How to assess this? To assess this, you have to ask how this symptom is affecting your job and daily activity. Do you need any kind of help? If the patient tells you that, yes, I need some help. Suppose the Parkinson's disease patient, for the tremor, he cannot eat or drink. So if the patient tells you that, for this tremor, I am not able to do my daily activity. At that time, you have to offer him for the social worker help. So these things will be assessed in the clinical communication skill. So if you follow the format and practice again and again with the given format, it is very much easy to crack the satisfactory mark in the clinical communication skill. Next, come to the differential diagnosis. In the differential diagnosis, at least try to tell at least 3 TD. And always tell about the points going in favor of the DD and points that is going against the DD. And what are the differential diagnosis you can tell? This differential diagnosis will be for the prompt. Like we are going to give you a list of differential diagnoses for each and every prompt. So you can use that differential diagnosis for this skill, like swallowing difficulty. So the patient is myasthenia gravis. In myasthenia gravis, the patient is having oropharyngeal dysphagia. So if the patient examiner asks you, what are your differential diagnoses? Or do you have any diagnosis or differential diagnosis? You can reply like that. For this oropharyngeal dysphagia, my first diagnosis is myasthenia gravis. But I have some other differential diagnosis of oropharyngeal dysphagia, like it can be stroke. But against that, I have not got any lateralizing sign. It can be dermatomyositis or polymyositis. But against that, I have not got any sign from the symptom from the history and sign from physical examination, like any tenderness in the arm or thigh that goes in favor of dermatomyositis or polymyositis. So we have to tell the differential diagnosis of the given prompt. So in this way, you can get full mark if you tell at least 3 TD for every prompt. And there is another extra thing that you have to remember for PACES exam. What is this thing? There is a special thing in the PACES exam, that is chest pain. And for sure, whenever chest pain comes in the PACES exam, in more than 90% of the cases, it is pulmonary embolism. It is 100% sure. And whenever the diagnosis is pulmonary embolism, you have to tell it in the first DD. You have to tell it in the first differential diagnosis, not in the second or third. If you tell it in the second or third, both the British examiner and also the native examiner will cut your mark. This has happened to myself during my first attempt in Bangalore Center. My case was a dummy case. My case was a case like she was admitted into the hospital for 3 days. She is a diagnosed case of COPD, and suddenly she is having chest pain. So I told that my first DD is pneumothorax, second DD is pulmonary embolism, third DD is I want to rule out acute coronary syndrome. So the British examiner awarded me 0, that is unsatisfactory. And native examiner, that is Indian examiner, gave me borderline, that is 1. And I missed the pass mark only by 1 mark. So that is why this will be my request that whenever any chest pain comes in the PACES exam, in more than 90% of the cases, it is pulmonary embolism. Look for the clue from the history, whether it is pulmonary embolism or not. How to look for the clue? There are 7 clotting questions. Whenever I am going to discuss the prompt of pulmonary embolism in the cardiovascular section, I will give you the written list of 7 clotting questions, what you have to ask to the patient to rule out pulmonary embolism. And whenever the pulmonary embolism is the diagnosis, always tell it in the first DD, never in the second or third DD, because this is very much important for UK. If you talk to your any colleague or any friends in the UK, you will see there that pulmonary embolism is a very much common finding for British people. That is why they are very much sensitive about pulmonary embolism. So this is for differential diagnosis. Next, come to the clinical judgment. In the clinical judgment, only two questions will be asked. What are the investigation? What are the management? And how to tell the investigation, how to tell the management, it will be given to each of the active participants with a separate recording. And there is some technique how to give the answer. Sometimes some candidates are very much smart. They give the answer in one line. So this is not the exam tree. If you give all the answer in one line, the examiner would jump to another question. And he will continue to ask the question until the time left. So there is a certain way how to answer the question. I will keep training to each candidate according during the course, how to keep the answer. And if you can answer what are the investigation and what are the management, you will get satisfactory for sure, even if you are not able to answer all the questions. But it creates some hidden pressure inside your mind, and this will affect your next station. So how to skip this part? I will give you training during the practice session, and I will tell you the tricks, how to pass the 5 minutes, how to cover the 5 minutes during talking to the examiner. Then managing patient concern is you have to meet the concern of the patient in wheezing without any jargon. So basically there are 15 minutes you will get to talk to the patient. After 13 minutes, you will be given a rang. You will be given a bell that you have 2 minutes left. And you have to complete all the history taking and physical examination within these 13 minutes so that you can get 2 minutes to meet the concern. Because sometimes the surrogate has a written list of concern. They can even ask at least 6 concern. So you need at least 2 minutes time at hand to meet all the concern. And 2 concern will be common for all the cases. One is what problem I'm having. Second is, do I need admission or not? Then according to the scenario, you can have other concern like, is it curable? Is it cancer? Do I need CT scan? Will it affect my child or not? So this is how to manage the concern. And maintaining welfare, it is easily covered by most of the candidate. If you do your hand wash before starting of the examination, and after completing your examination, give a thank you to the patient and try to cover his or her clothes. So if you approach in this way, you will get full mark in managing patient welfare. And most of the candidates get full mark here. So this is all for the mark sheet. Please ask me any question if anyone have any concern about the structure of the mark sheet. Please feel free to ask me any question. Dr. Obi has asked a question. So in all acute dummy patients, we won't expect any physical findings. Yes, doctor. Actually, in case of acute patients, you will not get any positive findings in favor of your diagnosis. You can get other positive physical findings. I am giving you an example. Like my case was a meningitis. And the patient was having history of splenectomy. So in meningitis, what do we expect? We expect the patient will have neck stiffness. But at the exam, you will never ever find any neck stiffness. But we have to check it. If you don't check for neck stiffness, you lose your mark. But the positive physical finding here was the splenectomy scar, not neck stiffness that I expect for any meningitis. Is it clear, Dr. Ovi? Doctor, can you hear me? Okay. So please ask me any question if anyone have any kind of question regarding the approach or course of the structure. If it is clear, then I can start discussion of the neurotopics, which has to be discussed today. So should I proceed? Please give me a thumbs up. so that I can understand that nobody has any question to ask.
Sir, just a request.
Yes, doctor.
Because I missed a few flow charts, like, the systemic review and examination and concerns, the flow chart thing. So is the recording available, sir?
Yes, the recording is available as a separate group for the active participants also. After each class, the recording is available there.
Okay, how to join the group, sir? Because I cannot find the link for that. WhatsApp.
Okay, are you at our group of Secrets Unveiled Paces?
No, sir.
Okay. So let me. Okay, I'm giving my WhatsApp number.
Okay.
Here, can you please? Okay, I'm giving my in the message section. You can make me a knock here. I will add you to the group.
Okay, sir. Thank you, sir.
Please tell me whether you are seeing. Are you seeing
Yes,
my
sir,
number?
I can see.
Okay.
Yes, sir.
This is my WhatsApp number. You can knock it here.
Okay, thank you. Thank you, sir.
Okay. So I'm proceeding to the main part of today's class, that is neurology section. Actually, there are lots of prompts from the neurology. There are basically 20 prompts. These are prompts for broader heading. Under each prompt, again, there are many other prompts. And what I have done regarding prompts, I have divided these prompts into 3 sections. This is done for each and every system. Like one is, triple star, another is double star, and the least important is 1 star. So what does triple star means? If you see the recent and the past cases, you see that these triple star cases are the most important that come every now and then in the PACES exam. Like today, in the UK, 2 cases came. One is low back pain, another one is dysphagia. These are triple star prompts from my list. So we have to put extra effort for these triple star prompts. So what are the triple star prompts from neurology? They are dizziness. Under dizziness, there are many other prompts. They are pre-syncope or lightheadedness, then syncope, vertigo. Then collapse is again triple star prompt. By collapse, we mean either syncope or seizure. Vision problem is also a triple star prompt. Under vision problem, there is double vision or transient loss of vision and gradual loss of vision. Apart from this vision problem, there are no other prompts in the PACES exam. Then transient weakness, tremor, headache, facial deviation, tingling and numbness, these are the triple star prompts. Then the double star prompts are fall or walking difficulty, recurrent weakness, proximal weakness, distal weakness, chorea, loss of memory, or dementia. Then the 1 star are the delirium or confusion, drooping of eyelids, grittiness of eye, weakness of hands, hemiplegismus, and hearing difficulty. So it will take 3 sessions, that is 3 classes, to complete all the neurology prompts. Today, we are going to discuss the dizziness approach, then collapse, vision problem, transient weakness, and also the tremor in this class. In the next 2 classes, we'll cover the rest prompts. So let's start from the dizziness. It is a very much popular case in the PACES exam. It is coming from the time immemorial. So in the PACES exam, actually dizziness is a vague term. It can mean vertigo, it can mean the pre-syncope or lightheadedness, or even it can mean syncope. So how to approach to dizziness? The first question will be, we have to differentiate whether it is vertigo or whether it is pre-syncope or lightheadedness. So we have to ask first, what do you mean by dizziness exactly? Do you feel the whole world is spinning around you? That is vertigo. Or you felt like you were going to pass out? That is pre-syncope or lightheadedness. We also have to ask, did you lose your consciousness? Because sometimes pre-syncope or lightheadedness can proceed to syncope. So this is the most important and the differentiating question you have to ask for any case of dizziness that comes in the PACES exam. That do you feel the whole world is spinning around you, or do you feel like you are going to pass out? Or did you lose your consciousness or not? Then there is a trick If the patient tells you that, yes, I lost my consciousness, the next question will be the duration of loss of consciousness. Why this is important? This is one of the most important question for any case of syncope. Because in the PACES exam, if the patient tells you that he lost his consciousness less than 1 minute, probably for a few seconds, like 10 or 20 seconds, this is a case of syncope. But if it is more than 2 minutes, it is hypoglycemia or seizure for sure, 100%. Sometimes in the history, the patient can give you that, can give you no history of doing any jerky movement, soiling of clothes. Just can tell you that I lost my consciousness for 3 minutes, or I lost my consciousness for 2.5 minutes. This occurred in the Delhi center. They have a very popular case. I have told you that hypocalcemia due to hypoparathyroidism due to thyroid surgery. Due to parathyroidectomy, due to thyroid surgery. So the patient was having loss of consciousness for, she told that it was about 2 to 3 minutes. And nobody noticed any jerky movement. So whenever the duration of loss of consciousness is more than 2 minutes, it is hypoglycemia or seizure for sure in the PACES exam. Remember this point. This is a very much important point to differentiate syncope from hypoglycemia or seizure. That is why duration is that much important. When I'm telling again and again, whenever there is any loss of consciousness, ask about the duration. If it is less than 1 minute, it is syncope. If it is more than 2 minutes, it will be either hypoglycemia or it will be seizure. Even if in the history the patient tells you that nobody noticed any jerky movement, swallowing of clothes, tongue bite, frothiness of mouth. Because this can occur sometime. Only by the duration, you have to differentiate syncope from seizure or hypoglycemia. So let's approach. I will discuss in a separate prompt the approach to the seizure or hypoglycemia. So whenever the case is dizziness, we have to ask, what do you mean by dizziness? Do you feel like the whole world is spinning around you? Or you feel like you are going to pass out? Did you lose your consciousness or did you pass out? Then, if the patient tells you that I was feeling like I was going to pass out, then the cause is either pre-syncope, or if the patient passes out, then it is syncope. And the differential diagnosis of pre-syncope and syncope is the same. So what is the differential diagnosis? The differential diagnosis, the mnemonic is National Communist Party. It is my mnemonic and CP. Here, national goes for neurogenic cause, communist goes for cardiovascular cause, and party goes for postural hypertension. Let's come one by one. The neurogenic causes of pre-syncope and syncope are vasovagal syncope, subclavian steal syndrome, carotid sinus hypersensitivity, and situational syncope. So what happens in the vasovagal syncope? In the vasovagal syncope, the patient will typically tell you that he was walking in a hot, clammy weather, in a hot, sunny weather. He was sweating a lot. And before getting faint out, she was feeling some nausea, vomiting, or excessive heat. This is likely vasovagal syncope, and she will automatically regain her consciousness within a very short period of time. Then it is a very much common case in the PACES exam. That is vasovagal syncope. Next, the subclavian steal syndrome. In the subclavian steal syndrome, I think all of you know what the subclavian steal syndrome means. Suppose the patient she's having affection of the left-sided artery. So whenever she's doing some activity with her left hand, she's likely to faint because the circulation through the posterior circulation of the brain will decrease. That will cause her to get faint. And this case has come in the Rawalpindi Center. The scenario was the patient was working at her kitchen. Suddenly, during taking some thing over the shelf, she was approaching and she lost her consciousness. So this is subclavian steal syndrome. Then carotid sinus hypersensitivity. Carotid sinus hypersensitivity usually happens with the old patient. Whenever during neck massage or during shaving, the patient can lose consciousness temporarily. So this is called carotid sinus hypersensitivity. Last, this is situational. So what does situational means? Situational means some vagal, that is Valsalva maneuver. Suppose anyone is having constipation, especially old age men, or having benign prostatic hyperplasia. So whenever they are doing some straining, the vagal nerve can be stimulated. This is called actually Valsalva maneuver. that can cause transient AV block leading to syncope. So these are the neurogenic causes of syncope. Then come to the cardiovascular causes of syncope. So cardiovascular causes of syncope are basically two types. One is outflow obstruction, another one is due to arrhythmia. So outflow obstruction basically means one outflow from the heart and another outflow is from the lung. Both of them are very much important because both of them have appeared in the PACES exam. The most important one is the outflow obstruction from the heart. This occurs in case of aortic stenosis and HOCM. In case of lung outflow obstruction, due to pulmonary hypertension, that is, the blood is not able to go from the lung to the heart, the patient is having syncope. And this case has come one time in the Thiru. The patient was having primary pulmonary hypertension, and at the UK, it came on background of obstructive sleep apnea, and due to sleep apnea, the patient was having secondary pulmonary hypertension. Due to outflow obstruction, the patient will lose his consciousness during walking or during doing physical exercise like running. So this is an important clue, that is outflow obstruction either from the heart or either from the lung. If from the heart, the diagnosis is aortic stenosis, the differential diagnosis is HOCM. If from the lung, it is pulmonary hypertension. Due to pulmonary hypertension, this can be due to primary reason or secondary reason. Is it clear to everyone how the outflow obstruction can cause cardiac syncope? If it is clear, please give me a thumbs up at the comment section so that I can proceed forward. If anyone have any kind of question, please ask me again. I'm ready to repeat again and again. Then the next cause is arrhythmia. This arrhythmia can have multiple causes. One cause can be post-myocardial infarction. So in the past medical history, if the patient tells you that, yes, in the past I was having a heart attack. So this can be like post-MI arrhythmia, like ventricular tachycardia or ventricular fibrillation. This can be drug history induced. Like in the drug history, the patient can tell you that I'm taking some antihistamine for recent flu. That is anticholinergic medication. That is causing long QT, causing some arrhythmia. It can be age-related. In the UK, whenever any old age patient that is more than 50 years comes to you with syncope, we have to rule out arrhythmia by doing ECG, and if nothing is found, we have to do 24-hour ECG. That is how done. So this is called age-related arrhythmia. Any age-related patient coming to you with syncope, we have to rule out arrhythmia. Then Brugada syndrome. To rule out cardiovascular causes of syncope, especially in case of young patient, there is an important history in the family history. That is any family history of sudden death. What does this mean? This means either there is a HOCM or long QT syndrome or Brugada syndrome. Like if you see the PDF there, it is written there that any family history of sudden death, it is important for syncope and palpitation. It is given there in the PDF. So these are the cardiac causes. For outflow obstruction, the patient will typically tell you that whenever I was running, I lost my consciousness. For arrhythmia, the patient will tell you that before being faint, I felt some racing pacing of heart. That is likely due to arrhythmia. But whenever any patient comes to you more than 50 years, even if he denies that he didn't notice any racing pacing of heart, we have to rule out arrhythmia. First by doing the ECG, then 24-hour Holter. Next, the postural party goes for postural hypertension. And the mnemonic to remember the causes of postural hypertension are hands. Here, H goes for hypovolemia due to any cause, like vomiting, like diarrhea, loose motion. A goes for anemia and adrenal insufficiency due to any cause. It can be primary adrenal insufficiency, it can be secondary adrenal insufficiency or anemia. For N, it is autonomic neuropathy, likely due to long-term diabetes mellitus or long-term Parkinson disease or Parkinson plus syndrome. Then D goes for drugs. These are vasodilator drugs. That is alpha blocker, ACE inhibitor, or any diabetes can be there. Then A goes for steroid withdrawal. This is very much important. There are some patients who are likely to take the steroid for a long period of time. And if suddenly they withdraw the steroid, they can have some dizziness, that is lightheadedness, and eventually syncope. Then all these differential diagnoses, that the neurogenic, cardiogenic, and posterior hypertension, can be ruled out only by asking 3 sets of questions. They are before, during, and after. So what are the before sets of questions? For the before, we have to just ask, what was he doing? What was he feeling? We have to ask, what are you doing before the episode? Suppose I would like to have some interaction with the candidate. That means who can give the answer. Suppose the patient is telling that I was standing from the sitting position, then I feel the dizzy and eventually I lost my consciousness. So what is the diagnosis here? What is the cause of diagnosis here?
Postural hypertension.
Yes, postural hypertension. Suppose the patient is telling you that I was running, then I lost my consciousness. What is the cause here?
Aortic stenosis.
Yeah,
Cardiogenic.
Yeah, cardiogenic or heart, anything can be there. Suppose the patient is telling you that I was doing market in a local market and it was hot and humid climate. So what was the diagnosis here?
Vasovagal.
Wonderful, doctor. This is vasovagal. So by asking what were you doing, you can rule out many differential diagnoses. The next question will be, what were you feeling? Did you feel any unusual sensation before this episode, like racing pacing of heart, feeling sick or excessive hot, any smell or tummy discomfort? By racing pacing of heart, we are excluding the arrhythmia. By feeling sick or excessive hot, we are excluding vasovagal syncope. By asking any smell or tummy discomfort, this is the sensory aura for any seizure or epilepsy. So the most important questions are for the before, and there, what we're doing, what we're feeling. Next, come to the during question. The question will be, there are 3 questions during for the during sets. Do you remember what happened during that episode? To differentiate syncope from pseudosyncope. Then we have to ask any jerky movement, tongue bite, frothiness of mouth, soiling of clothes during the episode. I am sorry to ask you that question. You are asking the patient that, did you soil the cloth? After asking this, we have to tell sorry. Then this is to rule out the seizure. Then any change of color during the episode. In the vasovagal syncope, the patient will become pale. In case of seizure, sometimes the patient can become cyanosed. That is why this question is important. And also remember, yes, anyone have any question, doctor? Okay, sometimes jerky movement can be there in case of syncope also. Whenever the blood circulation to the brain reduces, it can have some jerky movement. That is why only by jerky movement, you cannot identify that this is a case of seizure. Because jerky movement can also be there in case of syncope due to the transient ischemia of the brain. The only way to differentiate seizure from syncope, the only way to differentiate seizure from syncope is the duration. That is whether it is less than 1 minute or more than 2 minutes. That is why I'm telling again and again, the duration of loss of consciousness is very much important for any case of collapse. If the duration is less than 1 minute, this is for sure syncope, especially in the PCS exam. If the duration is more than 2 minutes, this is for sure either hypoglycemia or seizure. Please remember this. Then come to the after set of questions. For the after, we have to ask, how did you get back to normal? Did you take in sugar drink or did you get back to normal spontaneously? This is to rule out hypoglycemia. Then to rule out post-ictal confusion, we have to ask any confusion, headache, limb weakness after this episode. Then to ensure the safety of the patient, we have to ask any injury following the episode. So if you ask this before, during, and after sets of questions, you will get your diagnosis of any syncope or pre-syncope. So please share your views, or do you have any question regarding this approach to pre-syncope or syncope? If it is clear, please give me a thumbs up so that I can proceed further. Okay. 10. These are the most common causes of pre-syncope and syncope. Yes, anyone have any question, Doctor? Okay. 10. There is another cause. This cause has come one time in the Thiruvananthapuram and one time in the Pakistan. That is dizziness or lightheadedness due to hyperviscosity. This hyperviscosity was due to polycythemia. And in the Thiruvananthapuram, it came against obstructive sleep apnea. This obstructive sleep apnea was causing some low oxygenation that is causing polycythemia. And from the outside, the hemoglobin count was given, like 19 gram per deciliter. And after entering, you will see that he was an obese patient, was having obstructive sleep apnea, has now come with dizziness. That dizziness was due to hyperviscosity. At one time, at Pakistan, a case came with a ventricular septal defect causing secondary polycythemia, which is causing hyperviscosity or lightheadedness. This hyperviscosity does not cause vertigo. It causes lightheadedness. So this is an atypical cause that has come only for 2 times. One at Thiruvananthapuram and another one is in the Pakistan center. That is hyperviscosity causing dizziness or lightheadedness. But this is very much unusual. So if it is clear, then I can approach to the, anyone have any kind of question up to now? Okay, I'm going to.
Doctor, do you
Yeah.
have a recording of this? A recording of this is as you go fast today. So is there the recording? Any recording?
Okay, sorry,
of this
please
class?
tell me. I'm going too fast. Okay,
No,
I'm
it's
yeah.
no problem. If there is any recording of this class, there is no
Yes,
problem.
yes, doctor. You are active participant. You will get a recording of this. There is
Okay,
recording
thank you.
there. Okay, I'm going a
Okay,
little
thank
bit
you.
slower. No problem. Sorry.
No,
Thank you,
problem.
doctor.
No problem. No. You can go first. No problem. No problem.
Okay, actually, there are lots of things to cover. After that, we have
Yes,
to do the
yes.
practice
No
also.
problem. As there is some recording, no problem.
Okay. So if this is clear, the approach to pre-syncope or syncope, then I can proceed to the next thing, that is approach to the vertigo. And regarding any case of pre-syncope or syncope, we have to stop the driving. And if there is any episode of loss of consciousness, this line we have to tell the surrogate, because this is very much liked by the British examiner. What is the line? The line is, I would like to talk to your partner or the person who was present during that episode after our meeting today. This is applicable when there is any loss of consciousness. Because, is it clear to everyone? Whenever there is any loss of consciousness, we have to talk to the partner. After meeting the concern, we have to tell it to the patient or to the surrogate that I would like to talk to your partner or the person who was present during that episode after our meeting today. If you tell this line, you are likely to impress the British examiner. So please ask this question. It will prove that you are professional. So this is all for pre-syncope. Any question up to now? So this is all for pre-syncope and syncope. Let's go to the vertigo. The first question will be, what do you mean by dizziness? Do you feel the whole world is spinning around you? So this is vertigo. If the patient tells you that, yes, I felt like the whole world is spinning around me, then this is vertigo. So how to approach to vertigo? Whenever you are finding that this is a case of vertigo, we have to analyze the symptom using the mnemonic OD para. Here O goes for onset, that how did the symptom started? Suddenly or gradually? Did it started, how did the symptom started? Then when did it occur? that is for duration, for how long you are having this symptom. Then I goes for initial symptom. Is it the first time you are having this kind of problem? Then P goes for progression. Do you think your problem is gradually increasing day by day? Then A and R goes for aggravating factor or relieving factor. That anything increase or decrease your symptom. Then A goes for aggravating factor. Sorry, associated features. So after analyzing the symptom using the mnemonic ODPARA, we have to directly go to the differential diagnosis. First, we have to ask whether it is constant vertigo or episodic vertigo. How to ask this? We have to ask, do you have this spinning sensation the whole day, or does it come and go? If it occurs the whole day, all the time, this is constant vertigo. And if it comes and go, then it is episodic vertigo. And the differential, let's start from the causes of constant vertigo. So remember the causes of constant vertigo, that mnemonic is vice president of TMC, that is Dhaka Medical College. Here V goes for vestibular neuritis. B goes for posterior circulation stroke. D goes for drugs like phenytoin and gentamicin. M goes for multiple sclerosis. C goes for CP angle tumor. So these are the causes of constant vertigo. I will also tell you the screening questions for each. Regarding the vestibular neuritis, there are basically two types. One is vestibular neuronitis, another one is vestibular labyrinthitis. And the hearing will be affected in case of labyrinthitis. The hearing will not be affected in case of neuronitis. Remember this thing. And in the past medical history, the patient will have typically recent flu. And if the cause is episodic, that is, the spinning sensation comes and go, then we have to look for whether it is triggered or whether it is spontaneous. If it is triggered, then the causes are two. Either it is benign paroxysmal processional vertigo or it is due to postural hypertension. If it is spontaneous, then the differential diagnosis are two. Either it is migraine, it is also called basilar migraine. In this basilar migraine, there will be no headache, only vertigo. And it will be spontaneous, it will come and go in episodes. Then Meniere's disease. In Meniere's disease, typically the patient will be old and you will have some oral fullness. That is sensation of fullness in the ear. So these are the differential diagnosis of vertigo. Now let's discuss the screening question for each. For vestibular neuritis, we just have to ask the past medical history. Is there any recent infection or sore throat? For posterior circulation stroke, this is a very much important differential diagnosis. We have to ask about the past medical history. If in the past medical history, the patient tells you that he is having diabetes, hypertension, and also history of smoking, then posterior circulation stroke will be a differential diagnosis. And this is one of the most important differential diagnoses because for any vertigo coming in the PACES exam, we have to do in the physical examination, we have to do examination in the physical examination to rule out posterior circulation stroke. So I am again telling, for any case of vertigo coming in the PACES exam, in the physical examination, we have to exclude posterior circulation stroke, whether this is a case of BPPV, whether this is a case of Meniere's disease, whether this is a case of CP angle vestibular neuritis. We have to rule out posterior circulation stroke. So how to rule out from the physical examination? Just checking the finger nose test. I'm telling it once again, this is a must to do examination for any case of vertigo. By doing this finger nose test, you are ruling out the posterior circulation stroke. During physical examination, we have to do this physical examination must in any case of vertigo. Then for the drug, phenytoin and gentamicin can cause vertigo. For multiple sclerosis, we just have to ask, is there any episode of painful vision loss or any balance problem? Is there or not? This is a screening question for multiple sclerosis. For CP angle tumor, any kind of ixel, we just have to ask, do you have any headache? Is this headache increased by coughing, sneezing, or bending forward? By asking this question, you are ruling out CP angle tumor. For PACES exam, vestibular neuritis, posterior circulation stroke, and CP angle tumor are the most important one because cases has come from only this differential diagnosis up to now. Then for benign paroxysmal positional vertigo, we just have to ask that before this vertigo, did you move your head from side to side in the bed? If the patient tells you that the spinning sensation occurs whenever I'm moving my bed from side to side over my bed. So this is benign paroxysmal vertigo. But we have to rule out posterior circulation stroke for any case of vertigo by doing the finger nose test. And in case of benign paroxysmal positional vertigo, we have to offer to do the Epley maneuver. Sorry, disc Hall-like maneuver, not Epley. Epley maneuver is the treatment. We have to offer to do the disc Hall-like maneuver. We don't have to know how to do this maneuver because we don't have to do it in the exam, but we have to offer it. And the examiner will typically reply you that, yes, noted. Then posterior hypertension, typically we have to ask, do you feel dizzy after standing from the sitting position? For the migraine, it has up to now have never come. It will be a differential diagnosis to be ruled out in any young vertigo, but it has not come up to now. For Meniere's disease, we just have to ask, do you feel fullness inside your ear? So this will be the screening question and approach to any case of vertigo. In this way, we are completing the approach to dizziness. So this is the first problem we have covered up to now. There are lots of problems yet to cover. So please tell me if anyone have any kind of question regarding the approach to dizziness, that is vertigo, presyncope, or syncope. Yes, Dr. Shubhidhan said, what all cases has come so far with vertigo? Yeah, with vertigo, the most often I have seen up to now, BPP has come. Benign paroxysmal positional vertigo has come. But CP angle tumor can be given because this is a common case in the short case station. So there is a pattern in the PACES exam that sometimes they shuffle. Sorry, and syncope and presyncope. Okay, I'm telling you. What happens in the PACES exam? At one carousel, the case they keep in the short case station. They switch this short case case with the long clinical consultation for the next carousel. Like aortic stenosis is a short case station. So at one carousel, you can get it in the short case, the cardio station. But during the next day, this aortic stenosis case can be given in the long clinical consultation with the prompt of dizziness or syncope. This happens every now and then. As CP angle tumor can be given in the short case station, so this can be given anytime in the long clinical consultation also. That is why this is important. Up to now, I have seen just the PPPP coming, but we have to know all the differential diagnosis because we have to tell at least 3 TD for any prompt to keep you at the safe side to get the full mark in the skill of differential diagnosis. Now, Dr. Shubhadev has asked what cases has come so far from the presyncope and syncope. From the neurological causes, vasovagal syncope and subclavian steal syndrome has come. From the cardiovascular causes, all the causes has come. Nothing is left. And this is the most important causes of presyncope and syncope for the PACES exam. And also, always ask any family history of sudden death. From the postural hypertension, hypovolemia has come, Addison's disease has come, autonomic neuropathy we have to rule it out during any long-standing diabetes mellitus, but it has not come up to now with the prompt of syncope. Steroid withdrawal has come. So basically hypovolemia, additions, and steroid withdrawal. These three has come under the prompt of pre-syncope and syncope. And I will give you all the PDF of the cases that has come up to now from this prompt. And you have to take preparation after going through the recording, also going through the recording of the physical examination, investigation, and management that has to be done for each case separately. Then you have to start practice, and I will personally knock everyone every day, whether they were practicing it or not. Because practice is the main thing to gain the full mark in the PACES exam. And from this course, I will give you all that you need from the very beginning to make you the super smart in getting full mark in the long clinical consultation station. But during this 5.5 weeks, you have to follow the rule. You have to do regular practice. You have to report me regularly about your practice. And also, I will assess you one-to-one during the next session, upcoming session. Like today, we are going to discuss the musculoskeletal cases. I have to do one-to-one practice with the active participant. Is there any other question from this approach, Dr. Shubhadeep or anyone? Any kind of? Okay. Do anyone have any kind of question left so that I can approach to the next prompt?
No, thank you. We need to practice these questions to ask.
Yes, doctor. From today's prompts, there will be 32 cases. I will provide to you. Okay. So our next prompt is collapse. So basically, collapse meaning in the PACES exam, loss of consciousness. It will be either syncope or hypoglycemia or seizure. How to differentiate it? We have to ask about the duration of loss of consciousness. If it is less than 1 minute, this is syncope. If it is more than 2 minutes, it is either hypoglycemia or it can be due to seizure. This is for sure. And please don't forget it. Whenever there is any loss of consciousness, ask about the duration of loss of consciousness. Because this is very much important question to ask. So what will be the first question? The first question will be, did you lose your consciousness? You will be given a prompt like, Mr. Jackson has come with collapse. You will be given certain vitals like blood pressure, pulse, and temperature. Then you will be given in the prompt that talk to the patient, examine him, and meet his concern. So after entering to the station, after doing necessary introduction and asking the open question that what beings you had today, the patient will tell you that I had collapsed. Then the first question will be, did you lose your consciousness or not? If you lost your consciousness, for how long? Sorry. You have to check whether it is more than 1 minute or it is 2 to 3 minutes. Then the next question will be, how many times? Did it occur for one time or did it occur for multiple times? And when was the last time you had this collapse? After asking these 4 questions, we can directly go to the sets of questions of before, during, and after. And what are the before, during, and after questions that have already been discussed for the prompt of dizziness? I'm not repeating it once again, but you have to ask the before, during, and after sets of questions. And whenever there is any loss of consciousness, after meeting the concern, we have to tell to the patient that I will like to talk to your partner or the person who was present during that episode after our meeting today. If you tell this line, it will impress the British examiner. So please ask this line. That if it is a case of seizure, what are the differential diagnosis of seizure that we have to know? for the PACES exam. I am discussing the differential diagnosis that we have to know for the seizure for the PACES exam. Seizure can be idiopathic or it can be secondary. For the idiopathic seizure, you can be given a first episode of seizure. This is usually not given. This has been given only for one time. So we have to rule out all the secondary causes then. How to rule it out? I will discuss it during the secondary cause of seizure. The important thing is whenever this is a first episode of any seizure, we have to refer to the seizure clinic within a week. This is the must thing to do for any case of first episode of seizure. And sometimes the case can come that is recurrence of seizure. So if this is a recurrence of seizure, like in the past medical history, the patient is telling you that I was having seizure and now I am having another episode of seizure, then we have to look at the causes of recurrence. Like, was he compliant with the medication? Was there any missed meal? Were there any missed sleep, flashing of light, and stress? Excuse me, I'm having an important call. I'm just coming back within 1 minute. I'm sorry for that. Sorry, I had an important call to attend. I have just come back. So, am I audible now?
Yes.
Okay. So the seizure can be idiopathic or it can be secondary. In case of idiopathic seizure, there will be no secondary cause. So it can be given in the exam. It has come only one time as a first episode of seizure. So whenever there is no secondary cause and the cause is first episode, we have to remember that we have to refer the patient to the seizure clinic within a week. And if it is recurrence of any seizure, we have to check for the recurrence in the form of missed medication, missed meal, missed sleep, flashing of light, stress. We have to check about the compliance of the medication. We have to check whether he took his meal regularly or not. Were there any history of missed meal? Then we have to check about the sleeping pattern. That did she awake late at night? Then we have to check for the flashing of light. That sometimes the patient can tell you that yesterday night I attended some disco party. Then we have to ask about the stress. So this is idiopathic. This is actually not that much important for PACES exam. It has come only one time. The important one is the secondary cause of seizure. So what are the... Yes, doctor?
Can I ask one thing?
Yes, doctor.
So why is this flashing of light is important, and how do you ask this?
The patient will typically, you have to ask like, can you remember, do you have any exposure to the bright light yesterday or that somewhat before? The patient will typically reply with that yesterday night I attended a disco party.
Okay.
We just have to ask, do you have any exposure to the bright light before this episode? Actually, this is not that much important for any cause of seizure. The most important one are the secondary causes of seizure. So to remember the secondary causes that I have prepared a mnemonic, that is big monsters invade daily. Here big goes for brain. There are some brain causes that comes in the PACES exam as a cause of seizure. The brain causes are intracranial space occupying lesion, post-stroke CVST, that is cerebral venous sinus thrombosis, and metastasis. For ICSO, only tuberous sclerosis and neurofibromatosis type 1 is given in the PACES exam as a case of seizure. Suppose after entering into a patient station from outside, you are given that this patient has come to you with collapse. And after entering, you are seeing that he is a youngest male, so like 18 or 19 years, and he is having some adenoma sebaceum in his face. That is tuberous sclerosis. It is a very much common case in the PACES exam. And the cause of seizure in this patient is the ixol, that is any tumor inside the brain. It is also given with the neurofibromatosis type 1. Then post-stroke seizure is also important. It has come in the PACES exam with a history of stroke. In the cerebral venous sinus thrombosis is also important. It has come in the PACES exam with some history of clotting disorder. Like it has come one time with a history of taking OCP. The patient is having headache, and today, one morning, one is episode of fits. It came in the Pakistan Center. That is why CBST is another important. Another important one is metastasis. It has also come as a differential diagnosis of seizure. Like, okay, I'm going to discuss with you the real PACES exam cases after discussing the seizure to see how anyone can answer. That monster goes for metabolic. From the metabolic, hyponatremia, hypoglycemia, hypocalcemia, renal failure, and hypertension are important. I'll discuss you why, how this case comes. Hyponatremia usually comes with the background of CRT, with the background of suspicion of lung cancer. And for any type of cancer, to rule it out, we have to ask triple L. That is loss of weight, loss of appetite, lumps and bumps in the body. That INVADE scores for infection. This is not important for PACES exam. Up to now, no case has come with infection with seizure. Then JAS scores for cocaine and alcohol withdrawal. Cocaine and alcohol withdrawal both are important causes of seizure for PACES exam, especially for the UK candidates. So these are the differential diagnosis of secondary causes of seizure. And brain and metabolic causes are the most important one, especially the metabolic causes that has come. Like hyponatremia has come on background of CR, hypoglycemia has come on background of a CKD patient, hypocalcemia has come on background of parathyroidectomy with thyroid surgery, renal failure and hypertension has also come. Let me ask, and for any case of seizure, we have to stop the driving and we have to do important safety netting. What is the safety netting? Safety netting is avoid hobby like cycling, swimming, avoid heavy machinery and sharp cutting object. Don't close the door during taking breath. Remember, whenever any seizure case comes in the exam, we have to tell about the safety netting. If we miss it, we'll lose our mark in the clinical communication section. So never miss any safety netting. Okay, let me ask you a question. This is a real PACES exam case. By this, I'm going to start some interactive session with the candidates. I will now discuss. Yeah, doctor.
Before that, can I ask one question?
Yes, doctor.
Yeah. So, what is the relation between the seizure and the CKD? So, how does it come? How does it relate? Renal failure and
Sorry.
uh,
How did?
renal failure and the recurrent seizure, secondary
Yeah.
cause of seizure.
Yeah, renal failure is a secondary cause of seizure. In renal failure, the urea accumulates in the body. It is blood urea
Okay.
nitrogen that can
Okay,
cause
yeah.
it is my question. Let me ask you a question, doctor. Dr. Shubhadev, give me an answer. And I'm asking this question to all the candidates. Right now, I'm going to discuss some real PACES exam case scenarios that has come in the PACES exam to see how you can diagnose. A 45-year-old male has come with collapse. After taking detailed history, you are finding that this is a case of seizure. In the past medical history, the patient is telling you that he has long-term diabetes mellitus, that is for more than 20 years. He is a patient of CKD and he takes dialysis. So what do you, and from outside, his blood pressure is given 170 by 110. So tell me, what can be the differential diagnosis of
Hello?
seizure in this patient? Yeah.
Then dialysis disequilibrium.
Sorry? What?
Dialysis disequilibrium can be.
Yes, dialysis disequilibrium is one of the DD, but it will come at the last because dialysis disequilibrium usually minimizes after starting of some dialysis session. It is one of the DD. Any other?
Hypoglycemia.
Wonderful, doctor. Yes, hypoglycemia. Because the patient is having diabetes and she is having CKD. He is having CKD. And also in the drug history, there will be history of insulin intake. Any other cause can happen, doctor?
Urinic seizure.
Yeah, then what will be the important question to determine whether it is uremic encephalopathy or dialysis disequilibrium syndrome? What will be the important question? Yeah.
Compliance to the dialysis are regular or not.
Sorry, doctor?
Whether the compliance to the dialysis are regular or not. Whether he missed dialysis or not.
Yes, we have to ask, when was the last time you took your dialysis? How many times do you take dialysis regularly in a week? If the patient tells you that I take 3 times in a week, but the last dialysis was 7 days back, then this is uremic encephalopathy. Is it clear, doctor?
Yes, okay.
Any other cause you can tell? I would like to ask from other candidates.
Yes, sir. Another thing is you can have stroke also because blood pressure, hypertensive.
Yes, hypertensive encephalopathy can be there, doctor. Yes,
I
wonderful,
define
doctor.
bleed.
Yes. Any other cause, doctor? Only one cause is left.
I see bleed.
Then Polish.
Sorry, doctor?
Intracranial bleed for somebody with a high.
No. The patient does not give any. Yes, Dr. Siddharth has given the right answer. Hyponatremia. In advanced CKD, there can be hyponatremia. This is a real Paces exam case. So for this type of case, the most important question will be the dialysis question. How many times do you take dialysis in a week? And what was the last time you took dialysis? Isn't that interesting? Let me ask you another question. Let me give you another case to see how I'm giving you a scenario. You have to tell me the important safety netting and also the diagnosis. It is real Paces exam case. 65-year-old male has come to you with collapse. After entering the station, he's telling that he lost his consciousness while walking in the park. And this loss of consciousness was only 30 seconds. He was running, suddenly he lost his consciousness, then get back to normal state automatically. In the past medical history, recently he has been diagnosed with a case of angina with his GP. He went to his GP by complaining that I'm feeling some chest pain whenever I'm walking. For that, it was diagnosed by GP. For that, he has been started with some medication, like ACE inhibitor, perindopril, like isosorbide dinitrate, also aspirin and omeprazole. These are from the history. So first, answer me, what can be the diagnosis here? Only from the
Aortic stenosis.
Wonderful. Aortic stenosis. Now tell me, what is the important safety in here? You have to tell to the patient.
Some nitrates.
Wonderful. Who has answered this question, Doctor? Dr. Jana, I think. Yes. Why stop the isotopic nitrate?
Because of hypotension, sir. Like
Yes.
the
If you
cardiac output will be low as already with aortic stenosis. So again, this it
yes,
will decrease the afterload. So
yes, doctor. So in the safety netting, we have to tell the patient that stop that medication right now, and I have to talk to my consultant because this medication can increase your symptom. And if you solve the MRCP part 1 and part 2 questions, you'll see that all the mischiefs are done by the GP there. I don't know why they make the GP villain always. This was a misdiagnosed case. The patient was having aortic stenosis. That is why he was feeling chest pain while walking. So the GP thought that it is a case of recent angina, and he started him with isosulfite dinitrate, also ACE inhibitor, that are strongly contraindicated in case of aortic stenosis. So is it clear to everyone? Let me ask you.
Syncope.
Yeah. Yes, doctor.
So this is syncope, not
Yeah.
seizure.
No, this is syncope. I'm telling you. The duration of loss of consciousness was 30 seconds.
Right.
Is it clear, Dr. Shubhadeep?
Yes.
Okay. Let us just see why the past medical history, drug history, and family history is very much important. So let me ask you another question. This is also a basis case. This case came in Pakistan. It was a 30-year-old female with collapse. So after entering the station, the patient tells you that I had loss of consciousness for only 20 seconds. And what were you doing before that episode? After you ask this question, the patient replies you that I was cooking in my kitchen the weather was so much hot there. Suddenly, when I was picking for a pot over my head, I lost my consciousness. So
Vasovagal.
Yeah.
Or
One is vasovagal. Another thing. Sorry.
Subclavian Steele syndrome.
Wonderful, doctor. Yes.
Subclavian syndrome.
Yes, subclavian Steele syndrome. That was the case there, and these will be the two differential diagnoses. She was working in the hot, humid climate, and she was taking something over her head, and she was not having any pulse at her left hand. This was a case of Takasu arteritis, causing subclavian Steele syndrome. In any case of Takasu arteritis, we have to examine all the pulse and all the delay, radial delay, radiofemoral delay. We have to check for carotid pulse. We have to check for subclavian. We have to check for carotid bruit. We have to check for subclavian bruit on both sides. Also, we have to check for renal bruit. This is a must-do examination for any case of Takasu arteritis. Okay, let me ask you another question. This is a real patient second senior case. A 34-year-old lady has come to you with collapse. Okay, Dr. Shubhadeep has asked where to see the subclavian bruit. We have to see the subclavian bruit below the clavicle on each side. Above the nipple, below the clavicle on each side. Okay. 34-year-old lady has come with the collapse. After entering into the station, you are seeing that she has puffy face. So she is telling that I was feeling dizzy after standing from the sitting position, and today morning I had one episode of fits, that is seizure. I'm again telling you, I feel dizzy standing from the sitting position, and today morning I had one episode of fits. When they were asking about the past medical history, the patient is telling you that I am a patient of cystic fibrosis. The drug history, the patient tells you that I take steroid, but recently, due to a travel to Australia, I could not take the medication. So what do you think? What is the cause of collapse in this patient?
postural hypertension secondary to steroid withdrawal.
Yes. So adrenal insufficiency is the cause here due to steroid withdrawal. And this is the only case where pre-syncope, syncope, and seizure, 3 can occur simultaneously. Sorry, what I'm writing, it will be seizure. Pre-syncope and syncope is due to postural hypertension, and a seizure is due to the hypoglycemia. In case of adrenal insufficiency, we can have hypoglycemia that can cause seizure. So adrenal insufficiency is the only case where we can have both pre-syncope, syncope, and seizure. So let me ask you another question. This is a 60-year-old man with recurrent dizziness. Here, dizziness after entering the station, the patient tells you that I feel lightheadedness. That is, I'm going to lost my consciousness. I feel like I'm going to lose my consciousness, but have never lost any consciousness. Yes, Dr. Jena has told the right. Even hyponatremia can cause seizure. Yes, doctor, it is right. So the patient is telling you that I'm feeling lightheadedness. That is, I was feeling like I'm going to lose my consciousness. Regarding the past medical history, the patient tells you that I am a diagnosed case of hypertension and diabetes. Regarding the medication history, the patient is telling, sorry, I'm taking AC inhibitor and beta blocker, also sulfonylurea. So what can be the diagnosis here? He is 60 years old. He is taking
Hypoglycemic episode. Hypoglycemic episode.
yes, hypoglycemia. Any other TD, doctor?
Postural hypertension.
Postural hypertension.
But he denies that I feel dizzy at standing from the sitting position. He denies. Can you look from the prompt? Any other clue I have told during discussion?
Induced bradycardia.
No. I'm telling you that in autonomic neuropathy, the patient will feel dizzy standing from the sitting position. Look at the age patient. What I have told. Any aged person more than 50 years old, if ever comes to you with pre-syncope or syncope, what we have to rule out? Yes, doctor, arrhythmia. This is a must to do. Is it clear to everyone? Any elderly person coming to us with the symptom of pre-syncope or syncope, we have to rule out arrhythmia. Is it clear to everyone? Please tell me if it is clear or not.
Yes, sir.
Okay. Then let me ask you another scenario. These are real paces exam case scenarios. Sorry, what I'm doing. This is a case coming in the delay center. A 40-year-old female with collapse. And whenever you are asking, she is telling that I lost consciousness for more than 2 minutes. Forget about any jerky movement. She can tell you or not. In the past medical history, the patient is telling you that I had thyroid surgery. I think everybody will be able to give the answer. What is the cause of collapse in this patient?
Hypoglycemia.
Sorry, not hypoglycemia.
Hypocalcemia. Sorry, hypocalcemia.
Yes, hypocalcemia. And typically, the lady is given a handkerchief around her neck so that the scar mark is hidden. So that is why past medical history is very much important. Whenever in the past medical history, the patient gives you a positive history of thyroid surgery, remove the cloth around her neck, because this has been done to hit the scalma, to hide the scalma. Then, okay, there are many other cases also. It will be given to you to practice in details, but I should proceed now to the next prompts bit because there are many other prompts left. So up to now, do anyone have any kind of question from the dizziness and collapse? Any type of question, please feel free to ask me. Then I can proceed to the...
Is there a scenario where there is a psychiatric caused medication?
Sorry, psychiatric cause means
Neurogenic and psychiatric, like
No,
panic attacks? No.
never ever. This kind of cases has come in the PACES exam. You are not working, you are being assessed to work in the medicine unit. Psychiatric cases does not cause any seizure. It is actually pseudo seizure, conversion disorder.
Okay, sir.
Doctor, there are certain pattern of
Hello?
cases. Yes.
Hanji.
Yes, doctor.
Hanji?
Are you asking any question?
नहीं सर, sorry मैं.
Okay. So, doctor, what I'm going to tell you that there are a pattern of cases that comes in the PACES exam. If you look in the 3 to 4 year case scenarios, you'll automatically find the pattern. Actually, I have done this personally. So, due to any psychiatric cause of seizure, actually never ever this kind of case will be given to you in the PACES exam. This is for 100% sure.
Okay, sir.
Okay. So let's come to the next prompt. That is vision problem. This is also a triple star prompt, and this is very much important prompt for the PACES exam. This comes every now and then. So vision problem can be double vision, can be sudden or transient loss of vision, can be gradual loss of vision. Only these 3 types of vision problem come in the PACES exam. Apart from these 3 types, no other problems come in the PACES exam. So you can be given directly that this patient has come with double vision, or you can be given a prompt like this patient has come with vision problem. So let's start from the prompt of vision problem. Whenever you are given a prompt of vision problem, the first question will be, what do you mean by vision problem exactly? Is it double vision, or loss of vision, or blurring of vision, or difficulty in seeing the sides, or problem in night vision? This will be the first question for any kind of vision problem. I think this is clear to all. Then come, if the patient tells you that I see double, that is double vision. So what will be the next approach for any double vision? First, we have to confirm from the history that this is a case of double vision. How to confirm it? The first question will be, what do you mean by double vision? Do you see 2 images of a single object? That is double vision. The next most important question is, when you close your one eye, does the double vision disappear? This is to differentiate monocular double vision from binocular double vision. Because if the cause is monocular, then due to some ophthalmological cause, he is seeing double. But in the PACES exam, we will be given binocular double vision. That is, whenever one eye is closed, the double vision will disappear. Actually, there is a thing to understand in this case. So please ask me if this conception is clear. What is monocular double vision and what is binocular double vision? And this question has to be asked must in any case of double vision. Do anyone have any kind of question regarding the what does it mean? That is binocular double vision or monocular double vision? Please ask me, so I will discuss it in detail. Otherwise, I will proceed forward. I think you all understand what is monocular or binocular double vision.
I have some confusion, Doctor.
Okay, Dr.
Can you please
Shushma, wonderful.
explain?
See you, doctor, 100 times. Okay, actually, suppose this is our brain, and these are our 2 eyes. So what happens? whenever images comes from the eye, these are the images. Sorry, let me give another color so that it will be easier. So this is our brain. These are our two eyes. From the eyes, image comes and they coincide together at a particular point at the occipital cortex. So by combining both the images, we see only one object. Is it clear to everyone? From the image of this eye and also the image of this eye, both of the images coincide at one particular point of the brain. That is why we see only one image. If for some reason the alignment, suppose I am crossing it. Suppose this is another eye. For some reason, due to many reasons, the image from this eye, instead of coinciding here, is coming here because the eye has moved laterally. There are many reasons why this can happen. Suppose for some reason, the image from this eye is coming at this part of the occipital cortex rather than this part. So they are not coinciding at one point. If this happens, do you think the patient will see one image or two images?
Two images.
Yes, this is called binocular double vision. So whenever, suppose you are occluding this image from this eye, so then what will be the patient see? One image or two images?
One image.
Exactly, doctor. Is it clear now?
Clear. Okay, thank you, doctor. Clear.
And whenever, suppose another thing, whenever there is some refractory error inside the eye, there are many things. Like this is the lens, this is the, many things are there. This can be lens, there, aqueous humor, vitreous humor, many things will be there. And there are some refractions occurring inside everything. So for any reason, if the image, suppose, let me give you another, this is occipital cortex, and let me change the image color. These are two eyes. Suppose the images are coming here, but due to some refractory error, the image is not coming here. Instead, it is coming there. At the same time, if you close this eye, if there is some problem inside the eye, you will see double. If the problem is intrinsic inside the eye, due to some refractory error, because some image will come here, some image from here will come here. There will be many images coming from one eye inside the brain. Is it clear to everyone? Am I being able to make it understand what is binocular and what is unicular?
Yes, doctor. Thank you.
Dr. Shubhadeep, is it clear? Yes, Dr. Shubhadeep. Monocular is problem in eye. Binocular is problem outside the eye. Wonderful, doctor. Wonderful dialogue. Dr. Shubhadeep has given a wonderful dialogue. Monocular problem means problem inside the eye. And binocular problems means problem outside the eye. And in the PACES exam, you'll be given binocular problem. But in the history, we have to ask this question must to show the examiner that we are differentiating monocular double vision from binocular double vision. So that is why you have to ask the question, when you close your one eye, does the double vision disappear? These are the two most important questions for any double vision. Then the next question will be, when did it start? Did it start suddenly or gradually? And is it the first time? So after asking these 5 questions, we can directly go to the differential diagnosis. So what are the differential diagnoses that are important for PACES exam? They are myasthenia gravis, Graves' disease, sixth nerve palsy. This sixth nerve palsy can be unilateral or bilateral. The unilateral causes of sixth nerve palsy can be diabetes or vasculitis. The bilateral cause of sixth nerve palsy can be due to any raised intracranial pressure. Then third nerve palsy, 3/4/6 nerve palsy, internuclear ophthalmoplegia, and Wernicke's encephalopathy. For the PACES exam, only the first 3 are the most important causes of double vision. Apart from the other, they are very much less important. And from the sixth nerve palsy, only unilateral causes has come in the PACES exam, with the prompt of double vision. Bilateral six-nerve palsy has never come in the PACES exam with the prompt of double vision. Now, what will be the screening question? For myasthenia gravis, we have to ask, do you have any weakness that increases at the later part of the day? For Graves' disease, we have to ask, do you have any weather preference? And six-nerve palsy can be diagnosed only by seeing the patient. After anti-interstitiation, you will typically see that the eye, one of the eye is deviated medially. And in the past medical history, typically there will be any history of diabetes or hypertension. So these are the differential diagnoses. For any double vision, we have to stop driving must. Is it clear about the approach to double vision? Please ask me any question if there is any question. If it is clear, then I can proceed to the next. Sudden loss of vision. Please try to communicate with me by giving some reaction at least so that I'm able to. Okay, once again, what question? Okay, Dr. Osama has asked what question. For myasthenia gravis, we have to ask, do you have any weakness which increases at the later part of the day? For Graves' disease, we have to ask, do you have any weather preference? For six-nerve palsy, it can be diagnosed by seeing the patient. After we enter the station, you typically see that one of his eyes or both of his eyes will be deviated medially. And if you ask about the past medical history, the patient will give you some risk factor like diabetes or hypertension that is causing some vasculitis, causing unilateral six-nerve palsy. And third, 346 INO, Farnix encephalopathy are not important for PACES exam. That is why I'm not telling the screening question. In INO, it will be multiple sclerosis. We have to ask, do you have any painful vision loss or any balance problem due to cerebral involvement? For a Farnix encephalopathy, there will be history of alcohol intake, and the mnemonic to remember the Farnix encephalopathy is GOA. G goes for global confusion, O goes for ophthalmoplegia, A goes for ataxia. And for any case of double vision, we have to stop the driving. To remember the features of myasthenia gravis, I have a special mnemonic. That is the rule of D. So what are the rule of D? We have to start from the eye, then mouth, then chest, then arm, then jog, then driving, at last medical bracelet. So at the eye, we have to look for 2D. They are drooping of eyelids and double vision. At the mouth, we have to look for 2D. They are dysphagia and dysphonia. That is change in the voice due to bulbar paralysis. At the chest, we have to look for difficulty in breathing. That can happen in any case of myasthenia gravis. At the arm, we have to check for difficulty in climbing here. At the track, we have to look for carefully at the track history, looking for any track-related causes of exacerbation. For driving, we have to stop driving if there is double vision. At the last, we have to offer medic alert bracelet for any case of myasthenia gravis. So this is called the rule of D to remember the causes of myasthenia gravis. I think this is clear to everyone. If it is clear, please give me a thumbs up so that I can proceed to the next prompt, that is sudden loss of vision. Do anyone have any kind of question? Okay. Now, the next prompt is sudden loss of vision or transient loss of vision. In the PACES exam, permanent loss of vision is never given, is not given. Whenever you are given a prompt from outside lab, this patient has come with the problem of sudden loss of vision. After entering the station, you will typically find that it will be a transient loss of vision. So how to approach to this prompt? The first question will be, when did it occur? Did it occur suddenly or gradually? Is it the first time? Then, did it affect one eye or both eyes? That is, that loss of vision, did it affect one eye or both eye? Then we have to ask, do you still have the vision problem? Then we have to ask another important question. Remember, in the PACES exam, whenever any prompt, the symptom is transient. That is transient loss of consciousness. That is syncope seizure. Transient loss of vision or transient weakness. We have to ask the before, during, and after sets of questions. That is, what were you doing before this loss of consciousness? How did you get back to normal? Did you take any sugar drink? And what were you doing before this consciousness? Then how long the episode lasted? And how did you get back to normal? Did you take any sugar drink? This before, during, and after question has to be asked for any transient symptom given in the PACES exam. This transient symptom can be transient loss of consciousness, transient loss of vision, or transient weakness. Both of these three symptoms are very, very much important for PACES exam. I'm telling once again. Then come to the differential diagnosis. The mnemonic for differential diagnosis for sudden loss of vision or transient loss of vision is so many good drugs. Here so goes for stroke, that is amaurosis fugax, eye stroke. Many goes for migraine and multiple sclerosis. Good goes for glucose, and guys goes for giant cell arteritis. So how to screen for differential diagnosis? Whenever there is amaurosis fugax, we have to ask, did you feel like any curtain coming down over your eyes? If the case is amaurosis fugax, the patient will typically tell you that I was feeling like a curtain was coming down over my eyes. This is for sure amaurosis fugax, and this is the most important differential diagnosis for transient loss of vision in the PACES exam. And this will be one of the differential diagnoses if this case come in the PACES exam for 100% sure. For migraine, we just have to ask, after this loss of vision, did you have any headache? For multiple sclerosis, we have to ask, any previous episode of weakness or any balance problem? To rule out multiple sclerosis. To rule out hypoglycemia, we just have to ask, how did you get back to normal? Did you take any sugary drink, or did anyone measure your blood sugar at that time? This is to rule out hypoglycemia. For giant cell arteritis, we just have to ask, do you have any headache? So these are the differential diagnoses for sudden or transient loss of vision. And for any sudden or transient loss of vision, we have to stop driving must in the safety netting. So this is the approach for this prompt, that is sudden loss of vision or transient loss of vision. Please tell me if anyone have any kind of question. If not, please give me a signal so that I can understand and proceed forward.
So here also we'll get a majorly dummy patients only. Will be kind of mostly in the history.
Wonderful, doctor. Wonderful. Yes, you have got the point. This will be a dummy case for sure. You are getting the pattern right now, doctor. This will be a dummy case. Any other question from anyone? If it is clear, please give me a signal with any thumbs up or any reaction so that I can proceed forward. Okay, Dr. Mahmood has given me the thumbs up. Now let's go to the next problem. That is gradual loss of vision.
Just
So,
one
yeah.
thing. So in the DD, how do we give? We have to give all the DDs in the. Suppose somebody has a transient loss of vision comes and we get a diamond patient.
Yes,
So
doctor.
how do you
That
give a DD in that case?
you have to look from the history pattern. If the patient has past medical history of diabetes, hypertension, also taking insulin, so you can keep amino acids few works, also hypoglycemia. But we have to ask all the differential diagnosis question. And during telling the sets of differential diagnosis, tell all that you can tell all the differential diagnosis given in this sheet, but in this screen. But
Okay.
but you have to tell the point against going the differential diagnosis. Like the patient is not having any headache. So you can tell like that migraine can be one of the causes, but against that, the patient is not having any headache. That cause can be multiple sclerosis. But against that, the patient is not having any balance problem or previous episode of weakness. Are you getting my point, doctor?
Okay. Okay.
In this way, you can keep all the differential diagnoses given in the list. That is why you have to know sets of differential diagnosis for each prompt to ensure full mark in the differential diagnosis skill. That is why I'm going to give you from this course all the sets of differential diagnosis you have to remember for each and every prompt. Then come to the gradual loss of vision. So gradual loss of vision, the first question will be when it started. Did it started suddenly or gradually? Is it the first time? Then the fourth question will be, does it affect one eye or both eye? Next, you can directly go to the differential diagnosis. The causes can be cataract, diabetic eye disease, hypertensive eye disease, macular edema, clinically macular degeneration, clinically significant macular edema, retinitis pigmentosa, laser-treated retinopathy, and optic atrophy. For PACES exam, only 5 DT is important. One is cataract, diabetic eye disease, hypertensive eye disease, retinitis pigmentosa, and laser-treated retinopathy. If you want to remember, you can remember only these 5 DD. You can forget all other DD because optic atrophy has not come up to now with the prompt of gradual loss of vision. I have not found any prompt the last 3.5 years where optic atrophy has come with the prompt of gradual loss of vision. But if you want, you can remember the mnemonic made in toxin. You can see it in details from the recording. But I will request you to remember at least the cataract, diabetic eye disease, hypertensive eye disease, retinitis pigmentosa, and laser-treated retinopathy. And for this case, you have to know how to do the fundoscopy and pick up the findings. Sorry, Dr. Shubhadev, do you have any question?
This is all kind of ophthalmological things, diabetic eye disease, hypertensive eye. So all ocular problems. But yes, it's connecting.
Sorry, I did not get your point, doctor.
So this is all no, what I'm saying is this is all ophthalmological condition.
Yeah.
That will not any systemic condition.
These are systemic condition causing ophthalmological problem. The patient is having diabetes, that is causing some diabetic retinopathy. The patient is having high blood pressure. Both of them have come in the PACES exam with a prompt of vision loss. And you have to know how to do the fundoscopy. And during doing fundoscopy, never dare to touch the patient head. If you do unnecessary touch for the patient in the PACES exam, you are likely to lose mark in the PACES exam. That is why, for this case, we have to practice the fundoscopy. We have to know how to identify the soft exudate, how to identify the hard exudate, also the bleeding spots. These 3 things has to be identified. It is not necessary to know the stages of retinopathy. It will never be asked. Some candidates get confused that we have to know the stages of diabetic retinopathy. Never ever. If you are able to identify the hard exudate, soft exudate, and the bleeding spot, and if you tell it to the examiner, you will get full mark. In the PACES exam, they don't expect you to diagnose the stages of retinopathy. You just have to identify the hard exudate, soft exudate, and the bleeding spot. And another one thing is important for retinitis pigmentosa and laser-treated retinopathy. Whenever anyone tells you that I have gradual loss of vision, I have difficulty in seeing the sight, that is tunnel vision. Also, I have problem in night vision. Whenever anyone tells you that this states a problem, this is either retinitis pigmentosa or laser-treated retinopathy for 100% sure. So this is a trick. If you are not able to identify the bony spicules that of the retinitis pigmentosa, these cases come in the Pondicherry during this year. So how can you skip the cases? You can skip like this, directly go to the past medical history. If in the past medical history, the patient tells you that I am having long-standing diabetes, and in the history, if you ask any recent procedure, if the patient tells you that, yes, recently I had some eye procedure. So this is for sure laser-treated retinopathy. And if the case is retinitis pigmentosa, typically the patient will be young. So I'm again telling, if it is gradual loss of vision, then tunnel vision and night vision problem, it is either retinitis pigmentosa or laser treated, sorry. I'm sorry, I just lost my connection. So am I audible now?
Yes.
Okay. If in the exam, if it is gradual loss of vision, then tunnel vision and night vision problem, this is for sure either retinitis pigmentosa or laser-treated retinopathy for sure, 100%. You just have to ask about the past medical history. If in the past medical history, the patient has long-term diabetes and there is history of procedure in the eye, this is laser, sorry, I'm losing the connection. Okay. So if in the past medical history, the patient, if it tells you that he is having long-term diabetes, along with there is history of some recent eye procedure, the patient may not be able to tell you what the procedure was done. But if in the past medical history, the patient is telling he is having long-term diabetes, something like 20 to 30 years, then this is retinitis pigmentosa. Otherwise, it will be, then this is laser-treated retinopathy. Otherwise, it will be retinitis pigmentosa. So just identify whether there is any gradual loss of vision, then any tunnel vision or night vision problem. Is it clear to everyone?
Yeah.
Okay. Then we have to remember some causes of retinitis pigmentosa, because this year in the first date of Pondicherry, this case has come, retinitis pigmentosa. The patient was young. He was telling that he was having some tunnel vision with night vision problem with also color vision. So do you know why the night vision is affected in case of laser-treated retinopathy and also in case of retinitis pigmentosa? Just let me recapitulate one the basic thing. This is our eyes, our retina. This is the retina. So what happens? The rod coats, these are the rod cells. These rod cells are responsible for night vision. They are more predominant from mid to periphery. Basically, they are predominant at the periphery. And the central part is occupied mostly by the cone cells. So what happens in case of retinitis pigmentosa and laser-treated retinopathy? The peripheral part of the visual field, of the retina is gone due to some, in the retinitis pigmentosa, due to some bony spicules. And in case of laser-treated retinopathy, with some laser procedure, these parts are burned. That is why the rod cell is destroyed. Whenever this rod cell is destroyed, the patient is not able to see in the dim light. So he will have night vision problem. And in case of retinitis pigmentosa, the pathology starts from the periphery and gradually starts to proceed centrally. So what causes it? Gradually, the patient would have night vision problem. But with progression to the center, the patient will also have difficulty in color vision. because the cone cells are necessary for the color vision. So as the disease progresses, it will gradually affect the color vision also. And at the Pondicherry, that patient was having tunnel vision, then night vision problem, also color vision, loss of color vision. And he was also having balance problem. So let us know some causes of retinitis pigmentosa. If such case comes in the PACES exam, if you are able to identify that this is retinitis pigmentosa from the history and from the fundoscopy, and tell some differential diagnosis of retinitis pigmentosa, you will get your full mark. That has happened in the Pondicherry Center. It is not necessary to pinpoint identify what symptom fits the diagnosis most. Just tell some differential diagnosis of retinitis pigmentosa. The differential diagnoses are either Wisher syndrome, Kansari syndrome, Refsum disease, Bardet-Biedl syndrome, beta lipoproteinemia, or Alport syndrome. In Usher syndrome, the patient will have retinitis pigmentosa with hearing issue and ataxia. In Refsum disease, the patient will have retinitis pigmentosa with some anosmia, that is smelling problem, then short fourth metatarsalopharyngeal and peripheral neuropathy. In Bardet-Biedl syndrome, the patient will have retinitis pigmentosa along with obesity. Also, symptoms of hypogonadism. In beta lipoproteinemia, patient will have retinitis pigmentosa and loose motion along with ataxia. In Alport syndrome, along with retinitis pigmentosa, the patient will have kidney involvement in the form of hematuria. For Kansari syndrome, along with retinitis pigmentosa, the patient will have complex ophthalmoplegia, and the patient will be typically less than 20 years. And there will be involvement of multisystem like heart block and also diabetes and hypothyroidism, also hypogonadism. If you want, you can remember the feature, but this is not essential because in the PACES exam, they do not expect that you to examine to know the details of each of the cases. If you are able to identify that this is retinitis pigmentosa and you are able to tell some differential diagnosis, you will get the full mark. So this is the approach for gradual loss of vision. And again, I'm telling for hypertensive eye disease and diabetic eye disease, it is not necessary to know the stages of retinopathy because in the PACES exam, they will not expect this from you. You just have to tell the positive physical findings in the form of hard exudate, soft exudate, or any bleeding spots.
Wash your hand.
Is this clear to everyone? Please tell me if it is clear or so that I can proceed further.
I have one question.
Yes, doctor.
In laser treated retinopathy, the color vision will not be affected.
Usually not
Definitely.
affected, doctor, unless it is extensive.
Okay, and so difference between these two, this laser treated retinopathy and retinitis pigmentosa is whether the color vision is affected or not.
No, only from the past medical history.
Only from the past medical history. Color vision can be
Yes.
affected in the both the.
Sorry, color?
Color vision can be affected in both the cases.
Yes, color vision can be affected if the laser is done in the central portion of the retina. But typically in the exam center, the laser treated retinopathy patient will be older and the retinitis pigmentosa patient will be younger. And the laser treated retinopathy patient will have long-term history of diabetes. And if you ask him that, do you remember, did you have any procedure to your eye? He will give you the answer, yes, some procedure was done, but I cannot remember. Are you getting my point?
Yes,
Yeah.
and in diabetic eye disease and the diabetic eye disease, the patient will not have any channel vision. They will just have decreased vision. Both
They
eyes.
can have decreased vision, cannot have also.
Cannot have also.
Yeah.
Gradual loss of vision will be there.
Yeah, if there is gradual loss of vision against diabetes, then there is a gradual loss of vision, decreased vision. But not all the time, diabetic eye disease will have any vision problem. It occurs in case of advanced diabetes. Okay, doctor?
Yeah. Okay.
So if anyone tells you that we have to know the stages of diabetic retinopathy and hypertensive retinopathy, it is wrong. We just have to identify the positive physical findings and deliver it to the examiner. Is it clear, Dr. Shubhadeep?
Yeah, okay.
Okay. So anyone have any kind of question regarding this prompt so that I can approach to the next prompt? Please give me a thumbs up again if it is clear. Do anyone have any kind of question from this prompt? Please ask me. I'll be very happy. Okay. Let me go to the next prompt. This is transient weakness. This is also very much important. So this transient weakness can affect the upper limb. Mostly it is given as a prompt of affecting the upper limb. Sometimes it can be given as an affection of upper limb plus lower limb. Sometimes it is given only upper limb, or sometimes it is given affection of both upper limb plus lower limb. So how to approach to this case? When did it occur? First question will be that. Did it occur suddenly or gradually? Is it the first time? Did it affect the hand or leg, or affected the both? Any deviation of mouth during that episode? Then we have to ask the before, during, and after question. That what were you doing before this episode? How long it persisted? And how did you get back to normal? Did you take any sugary drink or not? And this will be typically a dummy case. And the differential diagnosis will be either TIA, hypoglycemia, migraine, multiple sclerosis, then seizure. So to rule it out, to rule TIA, we have to look at the past medical history, whether there was any risk factor or not. To rule out hypoglycemia, we just have to ask the after question. How did you get back to normal? To rule out migraine, just have to ask, after this weakness, during this weakness, did you have any headache? This is called also hemiplegic migraine. For multiple sclerosis, we have to ask, any similar episode of weakness earlier, or do you have any balance problem? For seizure, we have to ask, before this weakness, did you have any jerky movement? So it is called basically TOTS paralysis. After seizure, the patient can have some TOTS paralysis. It can mimic hemiplegia. It will be transient. So this is all for transient weakness. Please tell me if anyone have any kind of question from this prompt. And this is very much important prompt. This is because for PACES exam, TIA, amino acid fugax, these are very much likable exam prompt. That is why this case is also important. In the Delhi, this case came with the prompt like, this was a 45-year-old female. She came with transient weakness of one hand. She was preparing coffee. Suddenly, the cup of coffee fell from her hand. The diagnosis was TIA, and the differential diagnosis was hypoglycemia. She was having a history of diabetes, taking sulfonylurea. So please tell me if anyone have any kind of question from this prompt. If it is clear, please give me a signal so that I can approach to our last prompt that will be discussed today. Okay. And in any case of transient weakness, we have to stop driving for must. Then there was weakness of the hand or leg. This weakness can affect the hand, or it can affect the hand or leg in the PACES exam. So if it affected the hand only, we have to assess the functional capacity of hand. Must. If you missed it, you will lose your mark in the physical examination skill. If that affected also the leg, we have to assess the gait also. Remember this. These are important points to gain full mark in the physical examination section. Then how to check the functional capacity of the hand? Just we have to do two things. One is tell the patient, can you make a fist and open it for me? Second thing, you can tell like this, can you please button and unbutton your gown for me? This is the way you can check the functional capacity of hand. To check the gait, we have to tell, can you please walk for me? So I am again telling, whenever any transient weakness comes, if it affects the hand or if it affects the hands or leg, if it affects the hands, we have to check the functional capacity. If it affects the legs also, we have to check the gait also. And transient weakness, that is TIA, can also come with only hand involvement, without leg involvement. That is, one hand is only involved, no weakness in the legs. So this is all for transient weakness. Now I am coming to the last prompt of today. That is tremor or shakiness of hand. Let me drink some water. So this is another triple star prompt for PACES exam. So how to approach to any case of tremor in the PACES exam? First, we have to ask, any other body parts affected? The patient will typically tell you that, doctor, I'm having some shakiness of my hands for a certain period. Please help me, doctor. My next question will be, apart from this head, do you have any other body parts that is affected? Like the legs, like the head and voice. Like whenever there is affection of head and voice, this is essential tremor. Then the next question will be whether it is resting tremor or action tremor. Does it occur during rest or during some movement? To differentiate resting tremor from action tremor. Then the next question will be any change in handwriting. Why this question is important? Because in essential tremor, the handwriting will become bigger. Sorry, I'm again having loose connection. I'm sorry for that. Is my screen visible right now? Is it
Yes.
visible? Okay. So in essential tremor, the handwriting will become bigger. But in case of Parkinson's disease, patient will have micrographia. So the handwriting will become smaller. That is why this question is important. Any change in handwriting? So the three questions will be, apart from your hand, do you have any other body parts affected? Like the legs, like the head, like the voice. You have to give some example. Then we have to ask, does it occur during rest or during some movement? To differentiate from resting tremor from action tremor. Then we have to ask any change in handwriting, because in essential tremor, the handwriting will become enlarged. For Parkinson's disease, the handwriting will become smaller. Then we have to analyze the symptom using the mnemonic OT-para. I think all of you are acquainted with the OT-para. O goes for onset, D goes for duration, I goes for initial episode, P goes for progression, A and R goes for aggravating factor and relieving factor, and A goes for associated symptoms. We have to ask for each one specifically. Next, we can directly go to the differential diagnosis. So, to remember the causes of tremor, the mnemonic is end your liver anxiety with anxiety, alcohol, and coffee. So you are seeing your liver is being anxious. You are going to end your liver by doing anxiety for PACES exam, for LCC, by drinking alcohol, and also by drinking excess coffee. So what goes for this mnemonic? Here, N goes for endocrine, neurological cause, and drug-related cause. So what are the endocrine causes that can cause some tremor for the PACES exam? They are either hyperthyroidism or hypoglycemia. But what are the neurological cause? They are essential tremor, Parkinson's disease, and cerebellar syndrome. This cerebellum can be unilateral or bilateral. Then for the drugs, this can be beta agonist. Like the patient is having some asthma. For recent flare-up, he has started taking the blue inhaler. In the PACES system, they will typically tell you that blue inhaler or brown inhaler. Brown inhaler means corticosteroid, and blue inhaler means salbutamol. So due to increased intake of salbutamol, the patient can have tremor. So lithium can also have cause tremor. This lithium is taken due to bipolar mood disorder. This case has come. cyclosporin and tacrolimus can also cause hand tremor. This cyclosporin and tacrolimus comes in the PACES exam on the background of renal transplant. Then liver, liver. Liver goes for Wilson disease. There will be typical family history in the siblings or brother liver disease, that any family history of liver disease. Then anxiety, alcohol withdrawal, and coffee are another important causes. From these several differential diagnoses, there are two important differential diagnoses which the candidates miss the most. Most of the candidates will be able to screen all the differential diagnoses, but most of them will miss only two simple things. This is, I'm telling it from my personal experience. What are the two important things? They are anxiety and coffee. These are the simple things that most of the candidates miss. Otherwise, they screen for all other differential diagnoses, but simply miss these two things. That is anxiety. What about your mood? Do you have any stress? Do you take excess coffee? So now come to the screening question. For endocrine cause, for hyperthyroidism, we have to ask about weather preference. For hypoglycemia, we have to ask, did you measure your blood sugar? For essential tremor, we have to ask about the family history, whether his father or mother was having same kind of tremor, and from the and this tremor is action tremor. For screening Parkinson's disease, we just have to ask, do you think you are getting slower day by day? This is the screening question for Parkinson's disease. After you get positive symptom by any screening question, you can ask the other questions of Parkinson's disease. But this is the screening question, that are you getting slower day by day? For cerebellar problem, we just have to ask, is there any balance problem? If the patient tells you that, yes, I have balance problem, then the next question will be, do you tend to fall on one side or the both side? If the patient tends to fall to one side, this is unilateral cerebellar affection. If the patient tends to fall to both sides, this is bilateral. And the causes of unilateral cerebellar affection is, the mnemonic is very much simple, that is STD, sexually transmitted disease. Here S goes for stroke, T goes for tumor, and D goes for demyelination. So these are the unilateral causes of cerebellar affection. Then D goes for drugs. We have already told, liver, for Wilson disease, we have to ask, is there any family history of liver disease? And for anxiety, we just have to ask, what about your mood? Do you have any stress? For coffee, we have to ask, do you take excess amount of coffee or caffeine? I am again telling, most of the candidates are able to ask all the differential diagnoses except the simpler, these two causes, that anxiety and coffee. Is it clear to everyone? Do anyone have any kind of question regarding the differential diagnosis of tremor? Then, if any tremor comes in the PACES exam, this is affecting the hand. So we have to assess the functional capacities of the hand. So how to assess the functional capacity? We have to ask the patient, can you make a fist and open it for me? Then button and unbutton your gown for me. This is to assess the functional capacity of hand. And whenever any hand shaking or tremor comes in the PACES exam, must examine for thyroid swelling. This is to show the examiner that you are ruling out hyperthyroidism. The patient may not have any neck swelling, any thyroid swelling, but you have to act to check for it. Like you have to tell the patient that take a sip of water, don't swallow it until I tell you to swallow. Then after coming to the level of the patient, you have to tell the patient to swallow to see whether there is any thyroid swelling or not. And the details examination for each of the cases of tremor has been explained in the recording section of the physical examination. So this is all for the prompts for today. This was a long and big hectic session. Actually, I have to cover a lot of scenario. That is why it is being longer. So please ask me if anyone have any kind of question from this prompt and also from the other prompts. I'll be happy to ask any kind of question. I'd like to ask Dr. Shubhadeep, do you have any question?
No, we need to practice.
Yeah. Dr. Shushmita Apu, any confusion?
Until no, but if I have any confusion, I will text you later. Thank you.
Okay. If anytime you are having any kind of confusion, please put a message to my WhatsApp. I will come back to you as soon as I become free for my work. So, Dr. Amartya, are you there? Dr. Amartya, are you hearing me? Okay. Any other questions from any candidates, doctor? So right now, what I'm going to do, I'm going to distribute the cases like there are, so I'm going to give you some example like from the neuro one. Sorry. There are about 32 cases. These are PDF, written in detail, like what are the pictures, what are the questions we have to ask. These will be provided to the active participants. Also, at the separate recording, you will be given the recording of the physical examination and investigation and management for each of the cases separately. So what you have to do, you have to take preparation for each case and make your own notes. And after that, you have to start preparation between yourself, like the active members, and I will guide you. Whenever you are having any kind of confusion, I am there to help you. I will be there with you always during this 5 and a half week. After that, I will not be any responsible. So you have to start practicing, and during the next session, like next Wednesday, what we have to do, you have to practice one-to-one with me directly from this case that I will provide to you today. So if it is clear, I'd like to start the practice session after taking some 5 minutes break.
Okay. Okay. Thank you.
Okay, I'm requesting the active participants to be present because this will be your homework assessment right now. Okay, thanks for all. I will be back just after 5 minutes.